Yeah, Your Honor, we were contacted by the defense yesterday, not last night. Uh, The court made some designations on Mr. Cavanis, his deposition.
Okay.
And he was direct examined, he was cross-examined by me, he was impeached. They tried to rehabilitate him, and then he recanted his testimony. And the defense is trying to basically delete the recantation of his testimony. They've redesignated his deposition to delete that. And
All right, go ahead.
and you know, we would like some guidance by the court. I've never heard of this. I've never heard of someone just saying we're not going to play this in the deposition. It was not objected to. There was nothing unusual. He just recanted what he had previously said in his testimony, and there's really no legal basis for it that I can see. I've asked for legal authority. I've gotten none, and we're concerned about number one, we're about to rest. And, you know, we've got evidence. We've thought that the court's order on these depositions was the court's order. And they've got several depositions to play, and it seems like they want to basically propose new designations that delete what the court has already ordered, just for really the purpose of getting rid of unfavorable testimony. So I'll let Mr. Fletcher speak, and I'll let Mr. Meyer speak on our behalf on that, but that's an issue that we have. It's not just an issue with this deposition, but going forward, you know, we're about to rest. We can't go back and present evidence and you know, talk about these depositions. We don't even have copies of the videos, so we couldn't play them now in rebuttal or in our case in chief, obviously, because we don't even have copies. Okay. So that's troubling us.
All right.
Yep. Your Honor, it's up to the judge's discretion in terms of the questioning of the witnesses. It's in the evidence code. This was a deposition that was noticed by defendants. It was not cross-noticed by plaintiffs. And what we're really doing is shortening the deposition to account for the time that we already have. And what is being taken out is really defendants' redirect examination, plaintiffs' recross, defendants' redirect examination, and then plaintiffs' recross. And so it's not done to remove any evidence. The impeachment that plaintiff is talking about that they attempted in their cross-examination has already been made. And if the court wants to review, and you can start from the transcript from defendant's redirect, I think it's page 80, and then continuing forward, there's not this recantation of any testimony. It's really the back and forth of both sides trying to just rehabilitate their prior testimony. So the information is already captured in the direct and the cross-examination.
Okay. So while we're playing the two depositions that are about to go through the plaintiff, I pulled up Mr. Cavanis's. This is the 5/28/2025 deposition. I will review it. I will also review the current designations, objections, and counter designations. I will see kind of what my thoughts are, what my reactions are to that testimony, and then we'll just circle back to this.
Your Honor, and to make it easy, we can send you the draft designations, and we left spots for plaintiffs to object. You could just assume, obviously, they're objecting to what they're doing. But it kind of lays out what we're removing and actually leaves in red your orders on what subjects were to be taken out or what were to be left.
That would be helpful for context. Yeah, I would like that very much. And obviously, I'll just fill in any blanks with plaintiff objects. So,
and Your Honor, just to give you context, from what I understand, Mr. Cavanis at the beginning of the deposition said Mr. Bennett took the pictures of the truck that was involved in the accident, and at the very end he says, I don't know who took them. So it's an inconsistent statement. It's impeachment.
well, and I'm saying if it's that simple, we don't need 20 pages to get to that. And I'm kind of having this idea that's kind of where I'm going is maybe we just hit bits and pieces. I don't know. Let me just go through it while we're watching this. I'm not anticipating any objections from y'all during the depositions being played. So that'll give me a minute to look at those. And then I'll give you all my thoughts on it.
And Your Honor, I believe there's one section in the middle, like early on in the deposition. I believe they marked as page 21, line 11 to 23, line 23. I don't know why that's being asked to be removed. I just know that's a 2-page section they're asking not to play any longer. Shorter is better.
As my colleague says, shorter is better.
I don't necessarily disagree with that. So, okay, I'll look at the whole thing as y'all go. And again, I've got it all pulled up here, and as soon as we settle in, that's what I'll do. So,
Thank you, Your Honor.
all right, do y'all need any other housekeeping from me before I jump in?
Yeah, you're just leaving all the charge and verdict stuff to later.
Yes, just so we have a natural moment where we all go, hey, this is a good time for us to just give me some input on it. Again, we're not arguing a charge conference. It's just y'all to go this, and this, and whatnot. So, all right, plaintiff ready?
We are, Your Honor.
Defense ready?
Yes, Your Honor.
Yes, Your Honor.
Okay. If the jury is ready, they may come on out and grab their seats. They're certainly welcome to bring coffee or whatever they have with them. All right, Dan, I've given you the. Thank you, Your Honor. Liz has got it too. All right, you all may be seated. Welcome back, everyone. Again, you all came back. I should always say thank you for that. That's not lost on us that, y'all are obviously making huge sacrifices to be here. We all know that. We're very grateful for it. And a whole lot of folks you will never see in this courthouse and at their offices and with their families that you'll never see who are grateful for y'all for taking the time out of your lives to help us make a decision in this case. So I just can't say thank you enough. So where we're at is the plaintiff is on the tail end of their case. They have a few more witnesses to present to you all. And if everybody has your cell phone on you, go ahead and turn it off at this time. Make certain it's off. And with that said, I don't have any other housekeeping. You may call your next witness.
Your Honor, the plaintiff calls Dr. Eric Bendix for video deposition.
All right. Members of the jury, I've already given you the deposition charge. You will remember that you were to consider this just as if this was a live witness here, and I'll give you a formal charge on that at the end of the phase. All right. Miss Margaret, if you'll hit that light right there, and then y'all may push that up. It should, if I did this right.
I swear affirm the testimony today will be the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Good afternoon, Dr. Bendix. My name is Charles Scholl, and I represent Lewis Bennett in this case. I'm going to ask you questions about your treatment of Lewis. Dr. Bendix, what is your specialty?
I'm an orthopedic spine surgeon
How long have you practiced medicine?
since 96.
What is the name of your practice group?
Georgia Spine and Orthopedics.
And where is your office where you see patients?
We're here at my office in Roswell, 11650 Alpharetta Highway, Roswell, Georgia.
Do you have any board certifications, doctor?
I'm board certified in orthopedic surgery.
What is a board certification and how is one obtained, please?
Board certification means that you have attended an accredited orthopedic surgery residency program. During those 5 years of your program, you have to have passed all of your written and oral exams. And then after that, you're then tested on your first 2 years of treatment of patients in private practice with additional written and oral exams. And once you've passed all of those tests, then you're deemed board certified in orthopedic surgery.
Thank you, doctor. Can you walk us through your educational background, beginning with undergraduate and going forward?
Sure. I graduated from the University of Texas in Austin with a degree in zoology in 1992. I then completed my 4 years of medical school training at the University of Texas Southwestern Medical School, and that was from 92 to 96. After that, I then did a 5-year orthopedic surgery residency program at the University of Miami Jackson Memorial Hospital. That was from 96 to 2001. And then I did an additional year of fellowship training in spine surgery at the University of Rochester, and that was from 2001 to 2002. Since the fall of 2002, I've been in private practice here in Georgia.
Thank you, Doctor. Can you talk a little bit about what you generally do in your practice, including the proportion of clinical visits versus surgical?
Sure. Orthopedic surgery is the medical discipline that deals with conditions of the musculoskeletal system. So that's bones, ligaments, muscles, tendons, joints, discs, nerves. Within orthopedics, there's several subspecialty areas. One is spine. That's my area. So I deal with conditions of the neck, mid, and low back that we treat both with surgery and non-surgical means. So during an average week, I'm in clinic about 3 days, and then I'm in surgery usually 1, occasionally 2 days, and then often have 1 day of split between clinic and administrative duties. That tends to be about the average.
How many surgeries would you estimate you've performed during your career as a surgeon?
I've been in practice now as a spine surgeon since 2002, so a good 20 years now. I do about 150 cases a year, so maybe 2,000, 3,000 surgeries in that time, approximately.
Doctor, would it represent a substantial hardship for you and your patients if you were subpoenaed to testify live at trial?
Yes.
Was Lewis Bennett your patient?
Yes, he was.
Doctor, I have in front of you a certified copy of Lewis's records marked Exhibit 1. Do you see that?
Yes, I do.
Now, before the deposition, you and I compared the chart I have for Exhibit 1 with your treatment notes on your computer and determined that they are the same, correct?
Correct.
Are these medical records kept in the ordinary course of your business so you can look up the record if you need to review it, the treatment or care of a patient?
Yes, they are.
When did you first see Lewis?
My first visit with Mr. Bennett was on August 10th, 2020.
When you first see a patient, do you have a diagnostic protocol that you follow?
Yeah, we have a standard routine. We begin with a history of present illness, or HPI, where the patient explained to us why they're coming in, what deficit or disability or pain issue they might have, or combination of those. And then based on what their complaints are, that'll lead me to ask certain specific questions to kind of go down a certain path here or there. So when a patient tells me they have a certain disability or pain, I'll already have kind of a list in my head of most likely diagnoses, or what's called a differential diagnosis. And then based on information that I get either through the history, the physical exam, imaging studies, lab studies, that'll help lead me in one direction and rule out other potential explanations for their issues, or lead me in another direction. So we start with the history of present illness. We then go through their medical history, their review of systems, and then we will review imaging studies that they have. We may take new imaging studies, new MRIs, CTs, X-rays. We'll do a physical exam. And then with all of those different data points, we'll hopefully come to a conclusion of what we think is the most likely cause of what's going on.
Thank you, Doctor. The first thing you mentioned was a history. What did
Yes.
Lewis report had happened to him that caused him to see you on August 10th, 2020?
At the time, he was 52, a professional truck driver who said that he was involved in a collision, avoiding another truck on the highway that was swerving, and in order to avoid that 18-wheeler, he ran off the road and hit a guardrail. As a result of that, he developed neck pain and some weakness, and ultimately had to have emergent surgery done a few days later in the hospital.
Okay, so had Lewis already had an ER neck surgery before he saw you?
Yes, he had had that about 6 weeks before.
And what surgery had Lewis had already?
He had a surgery where they basically took pressure off the spinal cord in the neck. So what they did was I can show it on the anatomy right here. This is a model of the neck. It's an accurate depiction of the anatomy that'll help me explain what's going on with Lewis. What we see here, the structures in white are just the bones, is the bottom part of the skull. Then these are the bones of the neck, and the neck bones are just labeled with a number, 1, 2, 3, 4, 5, 6, and 7. Between each of those bones is a disc or a joint, and the disc is basically labeled based on the disc above and the disc below. So this disc right here, which is between the 6 bone and the 7 bone, would be the C6, 7, and the C stands for cervical, which is just medical speak for neck. On each side, you'll see a blood vessel that starts in the heart, down in the chest, and then runs up on either side, the right and the left, and will feed the brain. And then we see the yellow nerves going off from the spinal cord that's in the center there, or in that hollow tunnel in the middle. And these are the nerves that go off to the right arm, and these are the nerves that go off to the left arm. And then on the back side, protecting the spinal cord, is this arch of bones right here. In the case of Lewis, he had tightness in the spinal cord that ultimately resulted in damage to the spinal cord. And so the surgeons at the time, they elected to basically open up the back area here that was tight. And so that's the 1 bone, 2 bone, the 3 bone. Here they just removed that little piece. That's called a laminectomy. It kind of just left a sunroof right here. And then at these other levels, sorry, that's the 3 bone right there. 1 is right there, 2, and then 3. So they took that piece of 3 out to give some room for the spinal cord. And then at these levels, 4, 5, and 6, what they did is they opened, kind of like a trap door, opened it on one side to not take all the bone out, but just open up enough room to allow the spinal cord to have some room to breathe. And then at this very bottom level, the C7 bone, they did the same thing as up at the number 3 bone. They did a laminectomy. They just cut that bone out. All of these things that they did were the goal of relieving pressure on the spinal cord.
Thank you, Doctor. Did you see Lewis approximately 5 weeks following the wreck and 4 weeks following his neck surgery at the ER?
Yes, I did.
In your first treatment record, you report that Lewis had ataxic gait spasticity requiring the use of a walker.
Yes.
What does that mean?
He did not have a normal, steady ability to walk like most folks. He had spasming of his muscles, and he didn't have smooth movements, and he required a 4-point walker. It's like a cane, but with 4 spots on the ground to give him stability, and that was more likely than not, from the injury to the spinal cord that damaged his ability to be able to balance himself and to walk with a normal pattern.
Your first record mentions paresthesia. What does that mean?
Paresthesias just mean abnormal sensations. So he had some numbing, tingling, some burning sensations. Those would be paresthesias.
All right. The record also mentions diaesthesia and burning diastatic pain. What do those terms mean?
A little more specific for, once again, paresthesia, a weird sensation, but more kind of a burning descriptor.
Okay. You also report that he had shakes. Can you describe what you meant by that?
Forgive me, where is that mentioned?
Well, it's mentioned not on your first visit, but it's mentioned on page 15 or 16.
Of the very first visit?
No, it's not on the first
these,
visit.
On this stack.
I'll tell you what, we'll
Okay.
come back to that.
Okay.
What is a subjective finding?
Subjective finding is a finding that the patient relates to you, not something that can be independently verified.
And what is an objective finding?
An objective finding is a finding that can be independently verified. So, for instance, an X-ray or an MRI. It's a photograph. It doesn't require the patient just describing to you. It's independent of the patient.
Were Lewis reports of his symptoms on that first visit subjective to you?
Yes, the subjective component is his burning sensation and the tingling. Objective would be strength, any loss of strength, things like that, or abnormal reflexes.
All right. And you mentioned the physical exam. Did you attempt to verify Lewis's symptoms scientifically with the physical exam?
Yes, we did. So when we observed him, he did have that unsteady, spastic walk to him requiring the walker. We obviously saw the incision on the back of his head. That's objective. You can see the previous surgery there. There was also a reduced motion in his neck, which would be expected just based on the surgery. That will reduce your motion in your neck. And then he did have some weakness, primarily on the left arm. And then he had abnormal reflexes. Once again, you can't fake a reflex. It is what it is. And those would be the hyperreflexia that he had, as well as what's called an inverted radial reflex and a Hoffman's. Those are reflexes that you see with spinal cord injury.
And were those objective findings of a spinal cord injury?
Yes.
It also mentioned some positive finger jerks. What does that mean?
The positive finger jerks, I believe, are just another reference to the inverted radial reflex.
Okay. What did you expect at that time on that first physical examination? Was anatomically wrong with Lewis at that meeting?
Things that were wrong would be a reduced range of motion in the neck, his abnormal gait or ability to walk, his weakness primarily in the left arm, also his abnormal reflexes. All of those things would be abnormal.
Right. On page 4 of your first visit record, you wrote that he had a suspected spinal cord injury. Did you suspect that he had a spinal cord injury on that first visit?
We didn't have his imaging studies,
Okay.
but just based on what was done, when you do that type of surgery from the back of the neck, you're decompressing. You're trying to take pressure off of stuff. That's 9 times out of 10 what you're doing. And then based on his symptoms, what we could clearly see on physical exam, that's likely what was going on. And so we suspected that there was a spinal cord injury just based on his physical exam and his history, but we wanted to see the MRIs and any other imaging studies that would help support that.
And did you order MRIs?
We did. We asked for his prior imaging, and then I believe we also ordered new imaging.
Okay. And did you look at the diagnostic films of Lewis's anatomy after that first visit?
Yes, we did. We ultimately got a lot of his images from the previous facility. We did recommend that he at least begin physical therapy, at least start the standard post-operative protocol. When we saw him back on September 9th, 2020, about a month later, we had an MRI that was done on August 31st of 2020. And then that MRI, it showed the surgical changes that had been done, the bones that had been removed. It also showed disc herniations throughout his neck. So these structures right here, these discs, they're joints, but a good way to think of them is as jelly donuts. So they absorb shock. They allow for movement, they absorb shock. And they have a soft squishy center and a tough outer shell, kind of like a jelly donut. And in our normal activities of just sitting in front of a computer, watching TV, walking, your discs are experiencing certain forces on them that they can handle, should be able to handle. And those forces tend to squeeze down on a disc. And when they do that, the soft squishy center, the jelly, will tend to push out towards the edges. And it's up to that outer wall to corral the soft squishy center and keep it in place. If your neck is exposed to forces that are beyond what they can handle, when that jelly is squeezed out towards the edges, that outer wall might get overwhelmed and might get torn, and then some of the jelly can squeeze out. And that's what we saw in his particular case. He had multiple discs that had herniations, a couple of them that were touching or pressing on the spinal cord. And then we also saw damage to the spinal cord as well, which is seen as a bright spot.
Okay. And just to clarify, is when the jelly comes out of the donut, is that called a herniated disc?
Yes.
And could you mentioned it was pushing on the spinal cord.
Yes.
Okay. And so was that herniated inside the spinal canal?
When it herniates out, when it basically squeezes out, the jelly squeezes out, if it squeezes out the front, it'll affect your throat.
Okay.
Rarely do I ever see patients with those issues. Rarely does it go out the sides, just because the anatomy really doesn't permit it to go sideways. But the way we're designed, it can go out the back, where in that tunnel right there where the spinal cord sits. And if it pushes far enough back, it can injure the spinal cord. It's important to keep in mind, just the wall itself tearing without ever touching the spinal cord can hurt. There's lots of microscopic nerve endings that are all wrapped around that outer wall, all the way from the front, the sides, and the back, especially concentrated on the back. And those nerve endings, when they get either stretched by the wall bulging out or tearing, or when some of the jelly squeezes out, the jelly has chemicals in it that are very irritating to those outer nerves. They're chemicals that are great shock absorber chemicals. They work great if they stay inside the jelly. But if they squeeze out of the disc, those same shock absorbing chemicals are chemicals that are really irritating to those nerves on the outside. So you can have pain either because the wall gets stretched and the nerves fire, or because the chemicals irritate those nerves. So it can be a mechanical cause for pain or a chemical or both.
Doctor, did what you saw on Lewis's MRI film verify objectively the medical symptoms that Lewis described to you?
Yes.
Did the MRI show you photographic evidence of damage to Lewis's spine and his spinal disc structures?
Yes, they did.
After that initial visit, did you continue to see Lewis a number of times?
Yes, we did. So on the first visit, we said, let's get all your records, let's get all your prior imaging studies, let's see exactly what they did. Let's refer to the neurologist, let's start some physical therapy. And then we saw him back approximately a month later. He'd already done a few sessions of therapy.
Okay. And you saw him continuously over the summer and fall of 2020 after your initial meeting?
Yes, that's correct.
Going back to what I was talking about earlier, did Lewis on those visits demonstrate some bouts of shaking?
Yes,
Okay.
yeah, he would.
Doctor, did Lewis complain of shaking and want to know why he was shaking?
Yes, he did.
I want to direct your attention to page 16 of your records. This is a September 3rd, 2020 visit. And under assessment, it reads, patient was having violent episodes of shaking and spasms uncontrollably today after being propped up on pillows in a supine. He was visibly shaking from not being able to control his left arm and leg. See that?
Yeah, supine means being face up. So he's
Okay.
in pillows face up, and then he just had uncontrollable shakes during his physical therapy session.
Okay, so this was a physical therapy session.
Yes.
Did you actually observe that?
No, I did not.
Okay.
I've seen him in clinic, though, enough times to see that he would
Okay.
have those episodes of shaking, primarily the left arm, but yes.
And what was the cause of that shaking medically?
The spinal cord injury. So
Okay.
there are nerve pathways that there's nerves that will go from the brain to the spinal cord and from the spinal cord out to the arm or the leg. And there are relay pathways that will then go back, and those pathways normally have an up regulator and a down regulator basically in the spinal cord. And normally our patterns to hold our hand steady right here, that requires an intricate interplay of nerves both in the arm and mostly in the spinal cord to keep the hand relatively steady. If the spinal cord is damaged, that feedback mechanism of calming things down and of exciting things is unbalanced, and so that arm can start to shake and move because you don't have that intact spinal cord, the electrical wiring in the spinal cord anymore.
Were you able to see any kind of lesion or damage to the spinal cord?
Yes, you can see it on the MRI. There's a bright spot, which basically it's a bruise. You damage the spinal cord, and the problem with that is the spinal cord doesn't have the capacity for healing. So once it's damaged, that's it. Once those electrical wires have been damaged, those pathways are altered. And it just depends what electrical wires were damaged. Was it a nerve that's for sensation, for feeling light touch or vibration, or for positioning, so you can understand where your thumb and your hand are in position in space relative to your body, or are they for motor function, how to be able to grip with your hand or straighten your fingers out that could make those potentially weak. So it just depends on what electrical wires get damaged will result in what the symptoms are that the patient has.
Doctor, after you saw Lewis on several follow-up visits, what was your diagnosis of Lewis? I believe it's on page 42.
Okay. So on that visit, which is dated December 31st, 2020, we have cervicalgia, which means neck pain. That's just medical speak for neck pain. He also has multiple herniated discs, C3-4, C4-5, C5-6, C6-7. He also has a spinal cord injury. He also has some left-sided weakness, both from the arm and to a lesser extent, I believe, in the leg. Then he has the dysesthesias, which are the numb and tinglies and burning sensations that he has.
Okay. And were Lewis's symptoms consistent with that diagnosis you made?
Yes.
Now, you referred Lewis out, or attempted to refer Lewis out on a couple of occasions, and I wanted to explore that a little bit. You have a referral for Shepherd Center, and I believe you have a referral to Dr. Maloon.
Yes. Dr. Maloon is a neurologist, so I felt that he might be able to best handle different medications. Once you have a spinal cord injury, you can use different pills to hopefully help with some of the symptoms. Baclofen is one, which is kind of a muscle relaxer. I think he was also taking Flomax or tamoxifen for help with the bladder injury as a result of the spinal cord injury, or bladder dysfunction as a result of the spinal cord injury. And so neurologists can help with that. The Shepherd Center is a recognized spinal cord rehab facility here in Atlanta, and I felt that they would be able to help him with the rehab process.
Okay. And just if you could just describe maybe what you do as an orthopedic surgeon and where your sort of expertise begins and ends, and what a neurologist does in comparison.
A neurologist is a non-surgical specialist, and they help with conditions, injuries of the neurologic system. So nerves both centrally within the spinal cord and brain, and peripherally outside in the arms and in the legs. And so in this particular case, now that Lewis has a spinal cord injury, and we know that that's a permanent thing, and he has these certain symptoms, that's where a neurologist can come into play to be able to manage those symptoms, raising the baclofen, lowering the baclofen, raising some other medicines or things like that. There is even different types of pumps you can put in where the baclofen is injected directly into the spinal cord. That's not really my area of specialty. I'm an orthopedic surgeon, so I tend to be more of a carpenter. If it's bent or broken, I fix it. If there's something squeezing on something, I take pressure off. That's more of my area.
Okay, thank you, doctor. And orthopedically, we've talked about it a little bit. What treatments did you order for Lewis during those visits?
We gave him some medicines. We recommended therapy. We also made suggestions for the spinal cord rehab with Shepherd Center. We also discussed, because he was still having significant neck pain, that injections may be of benefit for that. The thing to keep in mind with the surgery that he had was that surgery took pressure off the spinal cord. And it did not really address pain, though. Pain was a component of his issues, and I felt that was likely because of the moving parts that were in the neck that can still move. Even after they did the surgery in North Carolina, that you still have motion in the neck. And the problem is that he had several moving parts in the neck, several discs that were damaged. So those moving parts could still move and theoretically still cause pain. And so in his particular case, after doing several sessions of therapy and several weeks, still continuing with the pain, that's when we said, okay, you may be either looking at living with this pain or considering a surgery. Let's try some injections. Let's see if those might be able to calm the pains down.
Okay. And were these epidurals and the physical therapy, were those an attempt to avoid surgery?
Yes.
Okay. Were you able to avoid surgery?
Not in his case, unfortunately. He still continued to have the pain in his neck. That was a big issue, and that's what I explained to him is, you know, what I'm talking about here is more of the carpentry of it, is you have damaged parts, several damaged discs that are basically, the bones are kind of grinding on each other. Those discs are still moving. Little chemicals are still leaking out from the discs. Those are those chemicals that it can irritate the nerves. The nerves are getting stretched. They're still being mechanically irritated, chemically irritated. I believe that that's likely a component of your pain. I told him that's probably not the only component of his pain, but a significant component. And so I said, at this point, you've done time, rest, pills, therapy, injections. You can either try to live with it, or if the pain is not tolerable, we can always consider a surgery to address those 4 damaged discs in the neck. And that will be a surgery where we come in from the front to address the 1, 2, 3, 4 discs that are damaged and still likely causing his pain.
And did you ultimately recommend that surgery?
Yes, we did. After several months, we recommended that he consider that surgery because he was still having quite a bit of pain.
Okay. And I'm just reading in your notes here from, I think it's September 9th, where it talks about an anterior cervical discectomy and fusion using PEEK cage, plate, screws, and iliac crest bone graft. Is that the surgery recommended for Lewis?
On September 9th, what I actually recommended was he try an injection first.
Okay.
If the injections didn't work, and at that point he would have done several weeks of rehab, therapy, pills, and an injection. If it still didn't work, then you could consider surgery as a last option versus just trying to live with the pain. So yes, that's a fancy explanation for saying we're going to glue those joints together to stop the painful movement.
Okay. Did you go over but you did recommend surgery to Lewis?
Then at the next visit, I believe he ended up seeing Dr. Feiga in late September. He ultimately had an injection with Dr. Feiga in October, late October. And then when we saw him back by November, he really wasn't getting enough relief. And at that point, we were 4 or so months out from his injury, from his surgery. He was still having pain. That's when I told him I didn't believe more time, more rest, more pills, more therapy, more injections were going to do the trick. I thought at this point, you're looking at either living with it or considering surgery to address some neck pain.
Right. Did you go over the risk of the surgery with Lewis?
Yes, we did.
And it reads in your notes on page 43, it talks about the risk of surgery are death, paralysis, dural tear, dysphoria, dysphagia, hardware breakage, bleeding, stroke, infection, and worsening pain.
Dysphonia, not dysphoria.
Dysphonia, I'm sorry.
Dysphoria would be sadness, which could happen too, but no, it was dysphonia, difficulty speaking, so
Okay.
yes.
Was this a major surgery that you recommended for Lewis?
Oh yeah, normally in most of my patients when I'm doing this surgery, I'm telling them this is probably going to be the biggest surgery of your life, but in his particular case, he just had one a few months before, so, but nonetheless, this is about as big a surgery as they get.
Okay. And what did you hope to accomplish with the surgery?
A reduction of pain
Okay.
in his neck.
All right. And doctor, I have from your notes, I've had a medical illustrator draft an illustration of the surgery, and I'd like you to comment on it, and maybe you could hold it up for the jury and look at it and see if you think that's accurate.
So what we're seeing here is a diagram labeled from A, B, C all the way through E of the surgery that we completed for Lewis. And the initial image here on A looks to me to be anatomically accurate. What we're doing is making an incision on the front of the neck. When we make that incision on the front of the neck, there's a lot of very expensive real estate there. There's large blood vessels, the carotid artery that's going up to the neck, up to the brain. Coming from the heart, there's also large veins and nerves called the vagus nerve that we have to slide towards the shoulder direction. And then we have these structures in blue, that's the windpipe, and just behind it in pink, a little thin line right there, you can't really see it too well. That's the esophagus or throat. We have to slide those in the other direction. And then you'll reveal the spine here. And this image B, what we have is this metallic instrument that's called a retractor. It just holds things out of the way and allows us to clearly see the spine there. The bones are in yellow and the discs are in blue. Once we've identified the spine, we now need to know which levels we're going to operate. We don't know if that's the 3-4 disc or the 4-5 disc, so we take a special x-ray. We have a portable x-ray machine in the operating room that's called a fluoroscopy unit, and we take pictures to be able to see which discs we're at. And based on that, we can then identify, okay, this is the 3-4 disc, that's the 4-5, that's the 5-6, and the next one below that is the 6-7. Now that we've identified that, we will then go one at a time and spread the bones apart, so we can then go inside and tear that disc material out with specialized instruments. They're called pituitaries and curettes that can also scrape the disc out. And we have to be very careful because what we see here in this image right here, this is the instrument called a curette going in. If you go in too forcefully, you can push disc material back, and the spinal cord's already been damaged, but you could further damage it. So what we want to do is very gingerly peel the disc material out without pushing anything back, and then until we get to the very back of the spinal cord, where we then peel it off of the spinal cord. And that's at the 3-4 disc that we're seeing there, but we also had to do it at the 4-5, the 5-6, and the 6-7. And once we've removed the damaged disc at each of those levels, we have to do something. We can't just leave the space empty, because then the bones are going to clink together. What we see here in red, the 3-bone, 4, 5, 6, and 7 bones, they'll grind together even worse and cause more pain. So what we do here in C is we scrape the end plates, the tops and the bottoms of the bones, to smooth them out and make sure we have no more remaining cartilage. Because what we want to do then is insert these little beige boxes that are basically plastic, and the plastic boxes are hollow. They have a hole in the center. And what we do is in this small inset image right here, we'll go in and remove bone graft. We actually cut out the bone. We'll core it out with a coring device. And we'll take that bone, stuff it into the little beige boxes at each level, and then insert those boxes into the disc space. Those are called cages. And what we want is to have that bone graft, the bone that we took from the pelvis that we stuffed into the beige cages, we want to have that touching the bone above and the bone below. Because that bone will ultimately, over the next several weeks to a few months, become glue that will glue this bone to that bone. And what that does is it stops that painful motion there. It also opens up, by spreading the bones apart, you're opening up the holes for the nerves that are shooting off in the arms, and that will hopefully help with any numb and tinglies that you might have that are the result of tightness. He can have numb and tinglies because of the spinal cord injury, but it's also possible that some of those numb and tinglies might be because the nerves are real tight. And so what we wanted to do is not only help with his neck pain by gluing the bones together and stopping the painful motion, but we also wanted to open up the holes that are going off on the right and the left, which we can see right here, where the nerves are coming out right here, the yellow on the right and the yellow ones on the left. Those little holes where they come out were rather tight on Lewis. So by stuffing these cages or these plastic boxes into the space, you can jack open each space and hopefully relieve some of the pressure on the nerves that are going off to the right arm and going off to the left arm. And if we do it correctly, that bone graft will actually touch from 3 to 4, 4 to 5, 5 to 6, and 6 to 7. Now, once we have those cages in place, and we've carefully put them in place and not push them too far to hit the spinal cord, we have to do something. We can't just leave those cages in place, because the gluing process, you can kind of think of it like putting Elmer's glue between your fingers. If you keep moving your fingers are never going to get sticky. And the same thing applies to the bones. If you just put the cages in there with the bone graft and then close up, those bones will still move when the patient turns their head right, turns their head left, looks up, looks down, and even that little bit of motion will interfere with the gluing process. So what we do is we put this little metal plate that you only see on profile here, a metal plate from C3, C4, C5, C6, and C7, and there's 2 screws at C7, 2 screws at C6, 2 at C5, 2 at C4, 2 at C3 to hold everything in place. So basically holding the fingers together so that the Elmer starts to get sticky, or holding the bones together so that they ultimately glue together. And that gluing process is usually a 3-4 month journey. And that's the basics of what we did for Mr. Bennett.
Thank you, Doctor. And I have in my records that that took place on March 8, 2021.
Yes, that's correct.
Okay. How did Lewis tolerate the surgery?
He did fine with the surgery.
How did Lewis do during post-op?
He did as expected. When you have a patient that's already got a spinal cord injury, they're going to have abnormal sensations, those burning dysesthesias, and so he's going to be distracted with that. It's very difficult to just concentrate on one symptom and say, hey, let's, or we're just going to focus everything based on your pain and define everything as a success or failure based on your pain when he still has all these other things going on. But over time, the bones did glue together, and over time his pains did decrease, and that was the principal goal of the surgery.
All right. And what post-op treatments did you order for Lewis during the post-op period?
We gave him medications. We treated him with a bone stimulator, which is basically just a large WWE type belt that kind of goes around the neck that emits a little radio frequency pulse that helps the bones heal. And then we recommended therapy for him, and then ultimately, I believe at the 3-month or 4-month mark, we did a CT scan, which is basically just a high-powered X-ray to really see the individual bone growth going from one vertebrae to the next to confirm that the bones had grown together. And that CT scan did show that the bone graft was healed at that point, which was the goal of the surgery.
Okay. Was the surgery a success in your mind?
It was a success insofar that it did glue, so we did glue all the bones together, and that it did help him with his pain, and most importantly, it's really Mr. Bennett. He's the one that feels those symptoms, so that's why we ask, like, okay, was it worth it? Did you get something out of it? And indeed, that's what he said on his final visit with us on December 15, 2021, is yes, I feel way better than before surgery. Okay, and then that's the goal.
Did you expect that Mr. Lewis would be in his pre-rec condition after the surgery?
Oh, no, he'll never be the same.
Okay.
Once you have a spinal cord injury, unfortunately, that's permanent. You cannot undo that with our current technology. All we can do is hopefully minimize his symptoms, the spasticity, the burning symptoms with different medications, and then the neck pain with the surgery that we recommended. So all these little things that we're doing, a pill here or surgery there or therapy there, will hopefully decrease the volume and give him a better quality of life. But unfortunately, he will always have pain and always have the burning discomfort, the non-tinglies, the aches, the spasticity. I did speak with him again today, just because that was the last time I spoke with him, was a year and a half ago or whatever it was how is he doing? And he said his pains are somewhere in the 4 or 5 range, depending on weather. He does have good days, he does have bad days, and then the pains can get worse. And he still has the spasticity issues, but
One of the jurors has just requested a quick break, so we're going to pause it. If you all, I got to do my dramatic reading. Here we go. Members of the jury, while you're outside of this courtroom, do not talk about this case with anyone or conduct any investigation about this case. You may only receive information from 2 sources: the evidence, which you'll receive from witness testimony and exhibits, and the law, which you'll receive only from me and no other source. These attorneys and their clients have worked for years to be here, and if you violate these rules, it will be a devastating event of this trial. Remember, there's a bathroom down the hallway as well. Again, this is a quick break. Don't turn your phones on. Just knock as soon as everybody's had a chance to step to the restroom, get another cup of coffee or whatever you need, and we'll immediately resume. All right, you all may step into the jury room or out in the hallway as you prefer.
that was the goal, was to decrease the pain.
In terms of the spinal cord damage, are you treating him for that, or is that another doctor that's treating him for that?
No, we're not treating him for that.
Okay. So your role in his treatment was just to fix his orthopedic issues, take pressure off the spinal cord, as you described?
The carpenter was
Okay.
to all the squeaky joints that were causing his continued pain. By removing them, we also did relieve pressure on the spinal cord, but the previous doctor had already done a good job of that by opening up the back of the neck and taking pressure off the spinal cord. The whole goal of taking pressure off is just, if you keep pressure on the spinal cord, you're going to basically suffocate the cord, and over time, potentially more nerve fibers could die off, and his function, his sensation, his strength, his spasticity could get worse. So the goal of taking the pressure off is to prevent further damage. It's not really to prevent any pain, it's just to prevent further damage. What we did is we went in there to try to help with his pain that he was dealing with.
Okay. So in terms of your work as sort of the carpenter, as you describe it, has Lewis reached what's called maximum medical improvement?
I believe so. This
Okay.
is, and I was explaining that to him today, is more likely than not, this is it. This is the new you. This is how it's going to be from now on.
Okay. And his, orthopedically with his neck, is his condition likely to get better or worse as he ages from an orthopedic perspective?
It's not going to get better. He could have some good days, have some bad days, as he mentioned to me, but this is pretty much where he's at. The thing we have to keep in mind is when you do a fusion, when you glue things together, you do necessarily put more stress on the neighboring joints. Now, we glued most of the neck together. There's not too many neighboring joints left, but you do have the C2-3 disc above, and you do have the C7-T1 disc below. So those joints are under more pressure. Now that you've glued those middle joints, the other ones have to work harder to pick up the slack. And so in theory, yes, those could wear out sooner, depending on what research you look at. About a 3% chance per year of needing an additional surgery. So in 17 years, more likely than not that he would need another surgery. But hopefully, based on his age, that will not occur. Yes, there is that risk.
Doctor, can a patient experience organ problems as a result of spinal cord damage from compression?
In his particular case, yes. This electrical cable, the spinal cord, does control all things below the brain, including organs. And for instance, his bladder is affected, and so he does have a neurogenic bladder, is what it's called, where the bladder doesn't function correctly because the electrical wiring that went to it passing through the spinal cord got damaged. And so, yes.
As an orthopedic spine surgeon, have you ever had a patient who experienced neurogenic bladder besides Lewis?
I've treated patients before, yes, that have had that.
Okay. Did you prescribe tamsulosin to Lewis?
I did not. I believe that
Okay.
was already prescribed at the facility when he left from North Carolina. And I don't believe we ordered any more, but let me see if we did. I believe he was already getting that before, and I don't believe we gave that to him.
Do you know what that medicine does?
Flomax is another name. It helps to relax the prostate to allow to initiate the urine stream, and so the goal is to hopefully help him be able to pee better.
All right. Have you been in touch with a Mr. Mike McCord, a life care planner that was retained by the plaintiff in this case?
Yes, I think they sent me some paperwork.
Your Honor.
Okay.
All right, pause it.
Thank you, Your Honor.
Objection overruled. You may continue playing the deposition.
A while back.
I'll represent to you that the life care plan that Mr. McCord, and I can show you a copy if you'd like, that he drafted provides that Mr. Lewis might come to see an orthopedic surgeon on one visit every 3 years over his lifetime. Did you contribute to that opinion?
I don't remember now. It's been so long. Do I agree with it? Yeah.
Okay. All right. Now moving on to another topic. Based on Lewis's medical history and your treatment as Lewis's doctor, did the truck crash where Lewis hit the guardrail cause the neck injury that led to the two neck surgeries and all the treatment that you have provided for him?
Yes, I believe so.
Based on Lewis's history and your treatment of Lewis as his doctor and your review of the diagnostic films, is the truck wreck the cause of the spinal cord damage, the cord compression, the bruise on his spinal, and the bruise on his spinal cord for which you have given him the prognosis you have described in this deposition?
Yes, I believe so.
Doctor, I want to take you back to page 1 of your records, please. On the first page of your records, you have a title called History of Present Illness. Do you see
Yes.
that? And you described before that Lewis told you he was had these symptoms. They started after his truck accident. Do you
Correct.
recall that? Did Lewis tell you that he did not have immediate symptoms following the truck wreck?
Yes, he said a day or two later he started having some left arm pain, numbness, and tingling on the arm and the leg.
Lewis tell you that he had symptoms 1 to 2 days after the wreck that got progressively worse over 6 days until he had the surgery?
Yes.
I sent to your office pages of Lewis's deposition
Yes.
testimony in this case. Were you able to review that?
Yes, I was.
Is Lewis's account of his symptoms in the days following the truck crash and in his deposition consistent with the history he gave you in your office on your first meeting?
Yes.
Does Lewis's lack of immediate neurological symptoms affect in any way your opinion that the wreck was the cause of his neck, disc, and spinal cord damage?
No. I would point out that in his medical records with the emergency room that he went to with Dr. Steet and also Dr. Chapman, that he mentioned that he had the symptoms the following day or so, which is not totally unsurprising. You know, after you have a collision, oftentimes you got a lot of adrenaline flowing, and so you may not notice pain. And in his particular case, his weakness was 4/5, so we grade strength on 5s. 1 is just a twitch, 2 is a little bit stronger than that, 3 is just enough to be able to lift your arm above gravity, the weight of that part or whatever. 4 is not completely normal, but some weakness, and then 5 is totally normal. In his particular case, his muscle grading was always 4, and sometimes patients don't notice that weakness until you do a specific physical exam on them. But in his particular case, I believe he said in the initial ER visits and also in Dr. Chapman's notes that he had weakness and he had neck pain within a day or two after the collision, that all lines up in my mind.
Okay. I'm going to, just for the record, show you what I'm going to mark, red marked as Plaintiff's Exhibit 3. Was that the deposition testimony that you observed from Mr. Bennett?
Yes.
Okay. And just for the record, the illustration or the medical illustration is Exhibit 2, just for the record. Why might someone have a delayed response where they have no neurological symptoms at the time of a collision, but then they have severe neurological symptoms in the days following that progress quite rapidly.
Once again, it's important to keep in mind that his condition, he had a spinal cord injury. It's called central cord syndrome. It's just when your head gets swung back violently and the spinal cord gets squeezed as a result, that can result in some weakness or weird sensations in the arms and less so in the legs, just based on the anatomy of how the spinal cord works. That weakness can vary from very dense, you can't lift your arms, to somewhat subtle. And so just because he mentions it on day 2, I think, after the collision, that he has some weakness, or it's mentioned in Dr. Chapman's note and Dr. Skeet's note, that doesn't, none of that is out of the ordinary. That's quite common. And as I said, when you're dealing right after the collision, you have a bunch of adrenaline flowing, you're very anxious, you may not be so focused on your grip strength. You might be more focused on just the collision that you were involved in and wanting to, in his case, get his load to point B and to be able to rest after that. But there's nothing that I saw in the documents here that didn't go along with the diagnosis of central cord syndrome that would stem from the collision. I don't have a better way to explain his symptoms than that. And you know, it's important to keep in mind, just because Lewis comes in and tells me, hey, I had an accident here and now I got this problem and this is what it is. Yes, I take him at his word, but that's not only that I do. I still have to look at all possible other explanations. So I have to look at, okay, could this be a metabolic, autoimmune, genetic condition? Could this be cancer? Could it be infection? All the main categories of things. Could that better explain what's going on? And what I'm left with after I review all these records from Dr. Chapman, Dr. Skeet, his deposition, and then what I've got, I don't have a better way to explain it.
Thank you, Doctor. With respect to moving to his physical condition and his vocation as a truck driver, have you ever filled out a commercial truck driver's medical certification?
No, I don't believe I have.
Okay. Well, based on what you observed of Lewis's condition at the time you examined him up until the time you first saw him till post-op when you released him from your care, did you feel that he was capable of lifting heavy objects or driving a commercial vehicle?
No.
All right.
I would say that's permanent too.
Okay.
The injury is permanent.
Thank you, Doctor. Just concluding, Doctor, were all the medications you prescribed for Lewis necessary to treat his conditions and symptoms?
Yes.
Was all the treatment that you gave Lewis reasonable and necessary?
It was.
Were all the medical expenses for which you charged Lewis customary for what other doctors charge in this market?
Yes, they are.
Were all your medical expenses fair and reasonable?
They were.
Was Mr. Bennett a cooperative patient?
Yes.
Was Mr. Lewis a compliant patient?
Yes, he was.
Did Lewis appear to want to get better?
Yes.
Did he do what you asked him to do without complaint?
Yes, he did.
Did Lewis ever appear to malinger?
No.
That's all the question. And finally, do you give all your opinions that you've given in this direct examination to a reasonable degree of medical probability?
I do.
Okay. I'm going to pass the witness. That's all the questions I have right now.
Thank you, Mr. Scholl. Dr. Bendix, for the record, I'm Quentin Fletcher, attorney for Transcontinental Cares and the insurance company Occidental. So I have some follow-up questions. As you sit here today, how many times have you given a deposition in a personal injury matter?
I do a couple a month.
Okay, so how many is that total since you've been an orthopedist?
That would be 20 or 30 a year. I didn't really do too many before 2011. Just, I hadn't been around long enough. So 2011 until now, so that's 10, 11 years, so a couple hundred.
Okay.
Probably.
How many depositions have you done with Mr. Scholl in the room here?
I've never met him before.
Okay. Have you ever sat in here for a deposition or given testimony at trial that you gave opinions related to injury causation that was for the benefit of a defendant?
That would be as an expert
For a
witness.
defendant, yeah.
I tend to shy away from that because I just like to be a treating physician, but I think the last time I did it was for a state trooper who was suing Taser Corporation because he was injured in a training exercise by Taser and alleged a broken bone in his spine as a result, but I felt that that was not related, so I think it was for the defense.
Now, in terms of Mr. Bennett coming to your practice, do you know how he was referred to you?
Sometimes it'll say it in the initial note. No, I don't see it.
Okay. Now, you testified earlier that it would be a substantial hardship upon you to testify in the trial of this case, and as well as a substantial hardship on your patients. If the trial was scheduled well in advance, could you make arrangements to attend that trial? If it was set well enough in the future?
Anything's possible, but once again, if I'm doing that, then I'm going to miss a day of surgery or a day in the clinic, so it will have an impact on patient care.
But you take days off. You take days off from the practice of medicine, though, right?
Do I go home to see my family? Yes.
Or you take vacations.
Yes.
Okay. All right. You talked about the subjective complaints of a patient. You said those subjective complaints are based upon what the patient is telling you, correct?
Correct.
Okay. And when you are listening to a patient describe their feelings or pains or sensations, you're relying upon that patient telling you the truth, correct?
Correct.
All right. You require that the patient be very candid with you about how they're feeling, correct?
Yes.
You wouldn't want that patient lying to you about how they're feeling, right?
Correct.
Because that could impact the way you treat that patient, right?
Depends on the information that's inaccurate.
Okay. But overall, you want the patients that you're treating to be honest with you, right?
Yes.
All right. Now, when you treated Mr. Bennett, you take Mr. Bennett as you see him that day, correct?
As opposed to?
As opposed to, do you look back to their prior medical history?
If it's important, yes. It
Okay.
depends on what information that I might need.
All right, you testified earlier that Mr. Bennett showed up to you complaining of neck pain and burning sensation, right?
Correct.
All right,
And
and
weakness.
And he told you that he had been in a prior accident,
Correct.
and that's the accident that underlies this matter, correct?
Yes.
Okay. And in treating Mr. Bennett, did you ever look to see if he had suffered any neck injuries that predated the accident?
Let's see. No, there was no prior history of spinal cord injury. So you would know if there was. He would not likely be able to drive professionally if he was. But all I have is the records from the patient and then also from the hospital that he treated at.
Okay. And the records from Mr. Bennett himself, what records were those?
Clinical intake sheet. He also brought his medical records, I think MRIs or whatever, at the next visit.
And is that the MRIs from the hospital that he had the surgery 6 days prior?
Yes.
Okay.
CTs and MRIs, I think.
Sure. How about medical records that predated that?
No.
You didn't review any, did you?
No.
Okay. You didn't review any CTs, X-rays, or MRIs that predated our accident?
No, I'm unaware of any MRIs or CTs that were done before.
Okay. Did you discuss with Mr. Bennett any treatment that he ever had on his neck that predated our accident?
No, unless it's in the record. Let's see if it says it anywhere. Nope, I don't see that anywhere.
All right. So he never discussed with you that Mr. Bennett had prior neck surgery in 1999. Do you recall him ever telling you that?
Let's see if it's listed in his records. No, I do not see that.
Okay. Well, I'm gonna hand you what I'm gonna mark as Defense Exhibit 1. Records from Savannah Neurology Specialist, which looks like the history and physical intake form from Mr. Bennett. All right, I'm handing you Defendant's Exhibit 1. Turn to page 2. Do you see where it notes neck surgery in 1999?
Yes,
All right, and you weren't, that wasn't brought to your attention in your treatment of Mr. Bennett, correct?
correct.
Okay. Did Mr. Bennett ever tell you about sustaining a blow to his head in 2013?
No.
Okay. And you testified earlier, and I believe that you said that,
Oh, forgive me. He did testify. I am aware of his neck surgery. He had a penetrating injury to the left side of his neck, and that's why they had to operate for a vascular injury to his neck.
okay.
Uh,
Well,
you can
and that-
see that on his x-rays. He's got a bunch of clips on the left side of the neck, so he would have
Is
seen that.
noted in your medical records?
It should be. Ultimately, we had to alter our surgical approach because I'm right-handed. It's easier for me to come in on the left side of the neck. But we had to come in on the right side of his neck because he'd already had the previous surgery back in 1999 for injured blood vessels in the neck. Not anything to do with the bones or the nerves, but the blood vessels.
And the blood vessels provide blood to where?
Carotid artery, so it goes from the heart up into the brain.
Okay. Does that provide any blood flow to the spine or the other parts of the neck?
You're probably going to get you do get some small branches off of that, but there's a lot of what's called collateral circulation, so you're getting blood flow from a lot of different areas. You can get them from these things, the vertebral arteries. In front where my finger is would be where the carotid is. So you take that out of the way and you'll see the vertebrals after that. The carotid is probably a larger component of blood supply to the bones and the blood vessels and the soft tissues in the area of the neck. But fortunately, that's two.
Okay. Well, you talked about in your testimony earlier that a blow to the head, which causes the head to violently snap back, was what Mr. Bennett likely incurred in our accident.
Yes, in all likelihood, in order to have a central cord syndrome, it requires an extension, movement of extending the neck. And so when that happens, the spinal cord, the area inside that canal is going to get narrower. And that's when that narrowness can get enough where it dings the spinal cord.
Gotcha. And you just demonstrated for the camera the head going backwards, correct?
An extension movement, that's extending the neck, yes.
Okay. So in terms of your testimony today, the damage that you witnessed with respect to Mr. Bennett's neck had to have been the head snapping back?
The spinal cord injury, yes.
Okay. You're not a accident reconstructionist, are you?
No, just a spine surgeon.
Okay. And you don't study biomechanics in terms of how accidents make the body move in certain ways?
Only insofar as it relates to orthopedics in the spine.
Okay, in terms of what you see with respect to the spine after an accident?
Correct.
Okay. In this case, have you seen any testimony or any description where there's someone saying that the head snapped back during this accident?
No, that would only be taken with video recorders or something like that.
Okay. And you, as you sit here, you don't know exactly how Mr. Bennett's tractor struck the guardrail, right?
Just from the police report, glancing kind of impact.
Okay. And Mr. Bennett's tractor was moving forward, correct?
Yes.
Okay. Now, you talked about in terms of a head snapping back. That could also be, your head snapping back motion could also be something hitting the head, correct?
Anything that causes the neck to go backwards. So in his particular case, he hit the guardrail. He probably went forwards and then came backwards.
Just give them all. In your treatment of Mr. Bennett, were you aware of him being struck in the head on the job in 2013?
No.
I'm going to hand you what's been marked as Defendant's Exhibit 2.
Oh, all right.
All right. In your treatment of Mr. Bennett, you did not see that record related to an accident, looks like on the job where he hit his head.
Correct. Yes.
Okay.
And it doesn't look like there's any evidence of spinal cord injury here from the physical exam.
Okay, but that describes his head hitting some bar while he's on the job, does it not?
Yes, it doesn't say where on the front of the head, the back, or the side.
Okay. But it nevertheless notes contact with the head, right?
It says sustained a single moderate blow with a metal object at work.
Okay. I'm going to hand you Defendant's Exhibit 3. And by the way, what was in your hand was Defendant's Exhibit 2 for the record. I'm going to hand you Defendant's Exhibit 3, which is a history and physical of Mr. Bennett. Could you read for me the history of the present?
So this is dated October 21st, 2013. Mr. Bennett is a 45-year-old right-hand male that was referred after a closed head injury on October 15th. He was working as a forklift operator when his vehicle suddenly pivoted upwards due to a heavy load, and he hit his head against the protective steel cage. He had a brief loss of consciousness, remember being thrown upwards, and his next memory is laying on the ground vomiting. He suffered scalp hematomas or bruise with no laceration or cut.
That would suggest trauma to the head and neck as well, right?
Not to the neck, just to the head. He
Okay.
says he has a scalp bruise.
So the collision with his head, that wouldn't necessarily impact his neck? Is that what you're telling me?
Let's see. There's nothing on the physical exam here that notes any abnormality of the neck.
Okay.
It just says that he has probably likely had a concussion. But
So
there's,
wouldn't
I'm
you
sorry?
agree with the general statement that where the head goes, the neck generally goes with it?
In what context?
If it were hit from the front and the head snaps back, the neck snaps back, right?
I'm not
I'm
sure
going
what
to
you're
object to
getting at. I
that.
don't quite understand what you mean.
Yeah, he said he hit the top of the cage.
Okay, if he hit the top of his cage, wouldn't there put pressure down onto the neck itself?
Depending on how much pressure it is.
Okay, exactly.
There's no mention here of anything abnormal with the neck other than the previously mentioned left-sided neck scar.
Great.
But other than that, there's no tenderness, normal movement. It says the range of motion of the cervical spine is normal. That should be abnormal if there was an injury to the spine. There should be something abnormal as far as reflexes, which there's not. There should be something abnormal as far as his gait, which there's not. Strength, there's no mention of any abnormality in strength. It says it's all normal. So there's nothing here that suggests anything to the spine.
Okay, I'm
Just
going to
a
hand you
scalp injury.
Defendant's Exhibit 4. I'm going to hand you Defendant's Exhibit 4, which is a medical record dated October 28th, 2013. Yeah. You could read for the record the assessment up there,
Assessment.
the history of present illness.
Patient presents to physical therapy status post-concussion. He was injured on October 15, 2013 after he picked up a load of lumber and it tilted the vehicle up and his head was slammed into the metal bars above. Some guys on the job came and got him out of the vehicle because he was disoriented. He went to the occupational health and then they sent him to Memorial ER. He has been referred to a neurologist but is waiting for them to schedule him for an MRI. Since the injury, he is having trouble focusing, blurred vision, dizziness, decreased balance, and he has been having major headaches since. He also states he gets nauseated since the accident. He denies any previous concussion. He also reports neck pain since the accident.
Okay. Did Mr. Bennett ever share this record with you during his treatment?
No.
If you wouldn't mind turning to page 3 of 4 of your treatment of Mr. Bennett on August 18, 2020.
All right. It was a physical therapy visit.
Great, and there's an assessment, correct?
Let's see, assessment, yes.
Yep. And then you state patient will benefit from PT sessions lasting several hours.
I don't state, the physical therapist states.
Okay,
since
this is the
their
physical
note.
therapy note.
On August 18th, yes, it's a physical therapy note.
Where does it say that it's a physical therapy note?
PT new on the first page.
Page 1? Is that where it says page 1 of the August 18,
Should.
2020?
Mm-hmm. And if not, the signature at the end is Blaine Woody, who is a physical therapist.
Okay. And did you prescribe physical therapy for Mr. Bennett?
Yes, he was out of surgery about a month or so out, so he said probably a good idea to begin some physical therapy.
Did he go to all the physical therapy sessions that you prescribed?
He ended up doing 1, 2, 3, 4, 5, 6. He did 6 sessions of physical therapy.
Okay. How many sessions did you prescribe?
Usually leave that to eval and treat, meaning leave it up to the therapist since they're the specialist in that to do their thing.
Okay. Is there a note that you're aware of in any of these records where the physical therapist said no physical therapy is necessary?
Where they said physical therapy is not necessary. I don't see that unless you can point it out to me.
All right. In terms of, if you wouldn't mind going to page 1 of your records, August 20th, 2020.
That's the physical therapy visit number 2.
Okay. It says objective, therapeutic exercise times 55 minutes for functional trunk. You see that?
Yeah.
Is that an exercise that would have been done here?
With the physical therapist.
Okay. Did you prescribe any exercises for Mr. Bennett outside of the office, so to speak?
Just like a home exercise program?
Correct.
I don't recollect. If I did, it would be in the notes.
All right, if you wouldn't mind turning to page 3 of 3 on the September 22nd, 2020 visit.
September 22nd. September. All right, that's Dr. Feiga's initial visit with Mr. Bennett.
It says assessment, 52-year-old male who was involved in a motor vehicle collision on July 1st, 2020. Result in cervicalgia, left sided weakness and dysesthesia, status posterior cervical laminectomy, and signs of incomplete spinal cord injury with C3, C7 disc herniation, C3, C5 disc herniation with cord compression, and C3 for myelomalacia. That is what you found with respect to Mr. Bennett's neck when you treated him, correct?
That's Dr. Feiga's note.
Okay,
The
but that-
pain management doctor, but do I agree with those things? Yeah.
Yeah, okay. But when you find a disc herniation or a cord compression, there's nothing in the injury that says exactly when it started, right?
No, not based on an MRI. So if you're looking at a photograph, no, there's not. That's why we don't just use an MRI or
Yeah.
just use an X-ray. We have to put all of these data points together to come up with a more likely than not scenario.
Yeah, and the more likely than not scenario relies upon what the patient tells you, right?
Well, that's their history, that's a component, but then we also rely on their review of systems, any pre-existing records that may be of benefit, any imaging studies, lab studies, their physical exam, and then you put together a more likely than not scenario.
But you, in terms of your treatment of Mr. Bennett, you didn't review any imagery studies, MRIs, or CTs that predated our...
Correct, I did not review any because apparently he never injured his neck before. Spinal cord before, or spine. He injured his neck with a penetrating injury to the blood vessel.
But in terms of understanding if he had hurt his neck before, that would require you reviewing prior medical records, correct?
If there are no prior medical records, then it's taking the patient history.
Now, in terms of post-surgery, in looking at Mr. Bennett's records, he smoked cigarettes, correct?
Yes.
Yeah. And smoking, and you would agree with this statement, has been demonstrated that it hurts the healing process, correct?
It does not help, for sure.
Okay. In fact, that when you have patients who have gone through this type of surgery, if they're smokers, you tell them to stop smoking.
Yes.
Okay. And in terms of this most recent conversation with Mr. Bennett, did you ask him if he still smoked?
No.
Okay. Would, in terms of discussing any smoking history, most recently with Mr. Bennett, we would defer to your medical records if you had a conversation with him about it.
Usually we'll mention that pre-surgical. Quit smoking if you are smoking.
How-
Will that impact the fact whether he got a spinal cord injury or not? No. But it can affect the bones gluing together after surgery. And that's one of the reasons why we use the patient's own bone. It has a higher ability for healing. The patient won't reject it. We also use that bone stimulator, that little WWE belt that emits the little radio frequency pulse. We give the patient vitamin D and calcium, so all of those things can help mitigate smoking issues or health challenges like diabetes or whatever that might be. But fortunately, in his case, he did heal.
All right. If I could direct you to page 404 of the medical record dated May 27th, 2021.
May 27. All right.
You there?
Yes.
Okay. If you look under plan, you recommended to Mr. Bennett that he stop smoking and stop using NSAIDs to allow the fusion to heal.
Yes. At that visit, he admitted to having re-begun smoking and that he would take some Motrin for the pain. And anti-inflammatories, while they help with pain relief, you actually need a little bit of inflammation as one of the ingredients to help the bone glue together.
Okay. And you were recommending he stop smoking and stop using NSAIDs because you found that the fusion was taking longer to heal.
Let's see, what is the date of that visit?
May 27th, 2021.
So we are 2.5 months out from the surgery. No, I didn't see that it was delayed. We're not really checking to see if the bones are glued together until at least the 3-month mark. So there was nothing there that showed any evidence that things were delayed. In fact, it looks like the x-ray that we took showed fusion consolidating nicely, is what we wrote there, meaning things are going along as expected.
Okay, if things were going along as expected, why did you recommend that he stop smoking and stop using NSAIDs?
Even some patients might smoke like chimneys and they still heal. They just, who knows, they got better genetics or somehow they're just able to go right through it. But why would I want to accumulate any additional risk? So my job is to minimize as much risk as possible. And so as a healthcare professional, it's a good idea for me just to tell any patient whether they're doing a fusion or not, smoking's not a good idea. In his particular case, it can increase the chance for a non-union, for the bones not to heal. And then so can the Motrin. It can increase the chance of not healing. Being that he had just re-begun smoking and just started taking the Motrin, okay, no harm, no foul here, but please stop. Everything's looking good on your x-ray, and then probably in another month we'll get a CT scan to make sure it's all looking good.
Okay, so correct me if I'm wrong, if I'm understanding you correctly here. As of May 27th, 2021, the fusions had healed, but yet you were just recommending that he stop smoking for his general health.
Healing, not healed, healing. He's
Okay.
still in the fusing process.
Okay, so
Those
as
first 3 months are when you're fusing, so it's a slow process.
Okay.
So it's kind of like baking a cake is what spine surgery is. Once I do the surgery, you're not fused.
Got it.
I just put all the ingredients together, put it in the oven. Now we got to wait 3 months for the cake to come out, for it to fuse, for it to be glued. And so during those 3 months, You want to minimize as much risk as possible. Don't go rodeo riding. Don't take NSAIDs. Don't smoke. If you're diabetic, keep your sugars well controlled. All things that could potentially increase the chance for the bone not to heal. In his particular case, at the 2-month mark, which is when we're seeing him there, x-ray's looking good. We're starting to see some bone growing, so things are looking good. But don't take any extra risk. Let's stop all those things.
Do you know if he stopped smoking?
Let's see at the next visit if it says so. Once again, it's based on the patient telling me. He says he stopped smoking previously and stopped the Motrin as well, is what it says at the next visit, which would be June 22nd, 2021.
But that's relying upon the honesty of the patient to tell you that, right?
Of course. I don't go to the patient's home to check up on them to make sure they're not smoking.
All right. Looks like my copy of your records ended a lot sooner before Plaintiff's Exhibit 1. If you wouldn't mind going to page, well, actually, it's your record dated June 22nd, 2021, so it's 4 pages that I have.
Okay, that was the note that we were just discussing.
Okay. All right. In June 22nd, 2021, the plan says, I recommend the patient continue participating in physical therapy. Is that your note or the physical therapist?
June 22nd, that's my note with the patient.
Okay. Do you know if Mr. Bennett continued with physical therapy?
I recommend participate in this speech. Let's see if they sent more notes to us. We might have those. June 22nd. I don't see any more PT records. Let's see. I see one from Team Rehab for June 30. Let's see. So he went June 30th to them. And I'm not seeing any more. Well, I see more in September 24, 2021. More notes from them. Team Rehab Physical Therapy. Let's see. And then it looks like that's the last one that I have.
Okay. Do you know how many other sessions of physical therapy you prescribed?
That I prescribed?
Yeah.
Once again, it's usually eval and treat. I leave that up to the specialist to decide.
Okay. And do you note any, at the back of your records, any note from the physical therapist that Mr. Bennett was no longer to go through physical therapy?
Let's see what the last one says. No, it says I just want to do more therapy. 2 times a week until November 1st, 2021.
And in terms of post-surgery rehab, you would hope that your patients follow through on what you prescribe for them, right?
Well, this form is actually them sending it to me for authorization. I don't believe I signed it. So if I didn't sign it, that might be why they didn't do additional therapy for him.
Okay, so, but you would expect the patients in their recovery to follow through on the rehab that you prescribe?
I liked him to do therapy, so at least a good 6, 8 visits, really. What you're trying to do with therapy after a fusion, regain a little bit of motion, hopefully decrease a little bit of spasm or stiffness. The reality is he's got multiple reasons for having spasm and stiffness, and if he was only able to do 2 or 3 visits of therapy, I don't think that's going to have any huge impact on his ultimate outcome, unfortunately.
got no further questions.
Dr. Bendix, if Lewis had a traumatic injury to the blood vessels of his neck 21 years prior to this incident with the truck accident in 2020, does that have anything at all to do with his spinal cord injury, his disc injury, or for any of the injuries or symptoms for which you treated him?
No.
You were also asked about an incident, it looked like it took place in October of 2021, I'm sorry, in 2013, which would have been approximately almost 7 years before this incident that we're here about today. And you were shown some exhibits. Did these exhibits indicate at all that my client had an MRI of his neck during that
No.
treatment?
No MRI of the neck and no abnormality on physical exam, at least, for the neck.
Was there any treatment at all given for his neck that you can see?
No.
Did that incident, as you've read those records in 2021, have anything at all to do, I'm sorry, did that incident in 2013, October 2013, approximately 7 years before the incident we're here about today, did that have anything at all to do with the spinal cord injury, the disc injury, or for any of the injuries or symptoms for which you treated Lewis?
No.
Doctor, you had said before that the spinal cord cannot heal itself.
Correct.
Would smoking have affected the spinal cord at all, or the healing process on that at all? If Lewis smoked, would that have made any difference?
The smoking doesn't help our bodies, but smoking didn't cause the spinal cord damage. In theory, could it allow some recovery of a few neurons more so? Theoretically, yes. Would it have any significant, appreciable difference for his final outcome? No. Diabetes, when it's uncontrolled, actually can, but smoking has not been shown in well-designed research to have that type of impact that diabetes would on neurologic outcome. It's not helpful, but it's not going to make a big difference.
Doctor, in terms of the November 17th, 2021 record, can you turn to that, please?
Okay.
Does it describe how many physical therapy visits, post-op physical therapy visits that Lewis had done at that time?
Yes, here it says on November 17, 2021, he's completed approximately 20 sessions with temporary relief, and now they're working to improve the strength of the left arm.
Okay. And in your opinion, was that sufficient for a post-op physical therapy regimen for Lewis's condition and what you would recommend for him?
Yes.
Did you also recommend a home exercise program for Lewis?
I don't remember doing that.
Okay.
I don't think it would ever be a bad thing if I say that. The reality is there's just so much you're going to get out of it. Once you have a spinal cord injury, you can therapy all you want, but you're not going to get the nerves back, unfortunately.
Sure. Now, at this time you were treating Lewis 2020, 2021. Was that during the COVID period?
Yes.
Okay. And was there any reference, or did Lewis tell you anything about any kind of family emergencies during that period?
He did have some financial difficulties, and I believe in April of 21, his father passed, so he had to suspend some treatment to deal with that.
Okay. And even in the post-op period, after the surgery, did he have trouble ambulating? I mean, walking around?
Yes.
Okay. Did Lewis indicate in your treatment of him any trouble sleeping?
Yes, he has had difficulty sleeping throughout his treatment with us.
Last question, Doctor. Did opposing counsel ask any questions on their cross-examination or give you any exhibits that change your opinion that the cause of Lewis's symptoms and the treatment for which you treated him was caused by the truck wreck of July 1st, 2020?
No, I didn't get any information or anything that would change my opinions.
Thank you, doctor. That's it.
May I have a follow-up?
Sure, yeah.
All right. Doctor, is it possible for someone to suffer a neck injury where symptoms show up weeks, months, or even years later?
Spinal cord injury, not usually. Usually you're going to be getting those symptoms, like in his case, once the adrenaline wears off, you start having some perceptions of the tinglies and the burnings and the weakness and things like that. Theoretically, could you damage a disc? A disc has lots of layers. That outer wall is like onion skin layers. Could you damage several layers and leave some behind, and then over time with activities, those remaining layers start to peter out over time? I guess in theory that's possible. I don't tend to see that too often in my patient population, but I guess theoretically that's possible.
Thank you.
We're done. Thank you, sir.
Into that one?
I'm sorry?
That's the end of that one.
Yes, we have a follow-up narrative that we'd like to read, Your Honor.
Any objection?
Yes, Your Honor, it's continuing testimony.
All right, what exhibit is that?
It's Exhibit 53. This is a narrative that was, he drafted after that deposition. It's a supplement to the deposition.
Yeah, it's all of the above, Your Honor. Continuing testimony, hearsay. I mean, he had an opportunity to ask him about that in the deposition, and he didn't.
Your Honor, can you review the deposition? He could not have answered that. Plus, there was no objection. They have 15 days to object, Your Honor. and they never objected.
Okay. I'm about to take a break real quick anyway. I'll take a look at this and, anything else before I take a look at this?
No, Your Honor.
No, Your Honor.
All right, members of the jury, we're gonna take a quick break because what's your next witness again?
Sorry?
Your next witness?
Dr. Malone,
And that's also? the
video
deposition?
deposition.
Okay. All right, so our next witness is gonna be another deposition. I think you said that one's closer to an hour?
Yeah, just a couple minutes over an hour.
All right, so quick break, and then we're gonna watch one more, and then we're gonna break for lunch. Members of the jury, while you're outside this courtroom, do not talk about this case with anyone, nor conduct any investigation about this case. You may only receive information from two sources: the evidence, which is you will receive from the witness testimony exhibits, and the law, which you will receive only from me, and no other source. These attorneys and their clients have worked for years to be here. If you violate these rules, it'll be a devastating event. You only step back in the jury room, knock as soon as you're ready, and I'll rule on this, and then we'll call the next witness. All
Yes,
right, so let's do these in the order that they handed me here at the last break, which is that I have plaintiff's exhibit 53, which is Dr. Bendick's narrative regarding, it looks like it's only regarding the animation, is that correct?
That's correct, Your Honor.
Okay. And what was the defense objection?
Your Honor, that's not a medical narrative of the treatment. That's just Dr. Bendix attesting to a demonstrative for expert testimony.
Okay.
Your Honor, the statute clearly provides that it can be related to etiology and it can look at a report or tests or interpretations of tests and speak as to causation, etiology. They didn't object to this. This was filed a year and a half ago. If they had these objections, they should have made it at the time. We could have taken Mr. Bendick's deposition. Now, because they didn't object, you know, we have the document here. It's relevant. It's relevant to what the jury's hearing, and it would set a bad precedent for them to object to something or not object to something, and then just object to it at trial when they waive their objection. They only have 7 days to object to this, and they're a year and a half late.
So it's up to the judge's discretion, Your Honor, and that is being posited for expert testimony, and it's not etiology of his treatment or review of the medical records. The animation that was been presented to you, Your Honor, when we argued about the animation for purpose of opening, was that it was compiled with the help of an animation expert to describe, you know, for experts. And so at this point, this has nothing to do with the treatment or interpretation of medical records. This is just him attesting to whether he agrees with the demonstrative exhibit or not.
Okay.
And Dr. Bendix wasn't designated as a testifying expert, just a treating physician.
We've given this to all the treating physicians. There was no objection, or maybe there was an objection, but you allow them to testify to it. It's just a supplement to his existing testimony. If we had had this at the time of his deposition, we would have given it to him.
Okay. All right.
Yeah, he's already been called as a witness, Your Honor.
Yes, I know. Okay. All right, Ms. Dabbs, do you wish to weigh in?
No, Your Honor.
Okay. All right, anything else?
No, Your Honor.
Anything else?
No, Your
All
Honor.
right, I'm going to allow it. So plaintiff's 53 is tendered and admitted over defense's joint objection.
Thank you, Your Honor.
And just to say it again, just to be really careful for the defense purposes, there's a lot of moments where Mr. Fletcher is objecting, and I'm nodding at Ms. Dabbs that may not appear on it, but you're adopting their objections.
Yes, Your Honor.
Okay, just want to make certain that was super clear on the record.
And while we're on the record, Your Honor, following reading of this medical narrative, plaintiffs, I anticipate, are going to put up the deposition of Dr. Malone. You want me to hang on? Yeah. Okay.
All right, and then we let the last juror in real quick. I suppose we have one juror sitting outside. Okay, we're going to do this next part then. All right, we paused real quick. Well, a couple of jurors came through into the jury room. The second matter for me to be dealing with was the amended designations from the defense on Mr. Cavanis. I have gone through the deposition. I've gone through the original designations in my order, and I've gone through the new amended designation. I want to make certain that it's super clear on the record that I do believe that 100% the defense is acting in good faith and trying to streamline their case. And that at this time, I guess I don't feel comfortable revisiting it with the tight time frame given plaintiff's objections. Unless you have something more specific, Mr. Scholl, that after reviewing what they've sent over, that you're in any way consenting to, or are you just objecting to the whole revisit?
Your Honor, we're objecting to the whole revisit for several reasons. We're resting, and we don't want to set a precedent going forward, but also it's just relevant testimony, and it's material testimony to big issues in this case, and he gives inconsistent statements for impeachment. So I haven't read the middle part, but I know I read the end part, and just because I don't understand how it fits in the whole context of everything, I think it'd be dangerous to start cutting things now when everyone has read everything in context, the whole deposition, and agreed that this is what we should put in.
Okay, well, let me be very clear with the defense that it is very clear to me that these were good faith attempts to streamline the deposition. There's nothing in there that's earth shaking, that made me go, oh, that's gonna totally change everything. But at the same time, I don't feel comfortable not having gone through it line by line like I did with the original, being able to say, yes, I'm comfortable with it. So I wanted to thank the defense for the effort and tell them that, if I had more time on it, I might reconsider it, but I just don't feel comfortable with it. So I just want to make sure the record is very clear that this was very clearly a good faith in streamlining it. And I went all the way back through it, through the new amended designations, and I don't feel comfortable revisiting from my original order.
Thank you, Your Honor.
All right, anything else, Mr. Fletcher?
No, Your Honor.
Okay. Again, if y'all had somebody smarter, faster, and better up here on the bench, you could get that, because again, it is a good faith effort, and I can truly, truly see that. Okay, anything else before we bring the jury back out?
Your Honor, the narrative is in the first person. I'm obviously not Mr. Bendix. Would you like me to explain the narrative, or would you like to explain that? Usually I just explain that this is a medical narrative, and it's.
I'm not touching it.
Yeah,
So-
that's not appropriate.
Yeah, it's okay. I'm not touching it. So that's the ruling. Y'all don't even need to stand up. It's your objection to that request is sustained. So, so the short answer is I'm not touching it. What you do with it is your business. If you draw an objection, I'll rule on it at that time.
All right.
So, but yeah, I get, I don't think we need anything else on the record. I'm not touching it. Okay, you can bring it through. We got a couple more jurors coming through. Oh, and I have the original here. There's the original. And that's 50.
It's a signed document. Wouldn't object to that.
Can I just say, I'm obviously not Eric Bendix.
Sure.
I'm reading his medical statement.
Sure.
Okay. Is that all of them? Okay. And is that enough? Okay. Anything else from the plaintiff before we jump into this last witness before lunch?
No, Your Honor.
Anything else from the defense? Mr. Fletcher?
No, Your Honor.
Yeah.
Okay. All right, then, if the jury is ready, they may come back up. Welcome back, everybody. If you'll take a second, if you have your phones in your pockets or purses, make sure they're off. And at this point, Mr. Scholl, you may call your next witness or handle your next matter of business.
Thank you, Your Honor. Ladies and gentlemen, this is the medical narrative of Dr. Eric Bendix, who you just saw. This is written in the first person, so I'm going to read it in the first person. Medical narrative of Dr. Eric Bendix, MD. I'm Dr. Eric Bendix, a board-certified orthopedic surgeon practicing in Atlanta, Georgia. I treated Louis Bennett for injuries following his truck accident, which occurred July 1st, 2020. I began treating him on August 10, 2020, about 5 weeks after the truck accident. I performed neck surgery on Mr. Bennett on March 8, 2021. I previously provided a deposition in this case on June 12, 2023, where I described my treatment of Mr. Bennett. Since the date of that deposition, I have been presented with a medical animation. This animation purports to show how the initial injury to Mr. Bennett's spinal cord in the truck accident progressed during the week following the truck accident. In particular, the animation shows the progression of the lesion visible on Mr. Bennett's spinal cord MRI films. I have reviewed an animation and re-reviewed the MRI films and reports for Louis Bennett. I've also again reviewed Louis Lewis's description of his symptoms in the week following the accident to compare that with the animation. It is my opinion, to a reasonable degree of medical certainty, that the animation fairly and accurately shows the likely progression of Lewis Bennett's spinal cord damage in the week following the accident. The animation shows the progression of Lewis Bennett's central cord syndrome following the crash, resulting in the present lesion, which is responsible for almost all of Mr. Bennett's neurological symptoms. I believe that the truck accident caused the neck discs of Mr. Bennett to push onto his spinal cord, and that this progressed vascularly over the next few days to cause a spinal cord lesion. I give the above opinions to a reasonable degree of medical certainty this 22nd day of January 2024, signed Eric Bendix, MD, and notarized. Thank you, Your Honor.
And defense objection is noted for the record. All right, Mr. Shaw, you make all your next witness.
Let's go ahead.
Your Honor,
Wait.
we're calling Dr. Alan Malone via deposition.
Okay. I should have done what I'm supposed to do up here. Okay. Dan and Liz are nodding at me, so.
This will be the deposition of Dr. Alan Malone. Today's date is January 19th, 2024, and the time is 11:58 a.m. And we're on the record. Would the court reporter please swear in the witness?
Hey, good afternoon, Doctor. Do you swear or affirm that the information you'll give this afternoon in this deposition will be the truth, the whole truth, and nothing but the truth? So help you God?
I do.
Thank you, sir.
Good afternoon, Dr. Malone. I know we talked on the phone, but let me reintroduce myself.
Yes.
My name is Charles Scholl, and I represent Lewis Bennett in this case. I'm going to ask you questions about your treatment of Lewis.
Okay.
All right. Can you tell the jury your full name, please?
Alan Malone.
What is your specialty, Dr. Malone?
I'm a neurologist
How long have you been a doctor?
since December of 1975.
And what is the name of your practice?
Hope Neurology
And where is your office where you see patients?
in Sandy Springs, Georgia.
Do you have any board certifications, doctor?
I do.
What does a board certification mean, and how is one obtained?
It means that you spend time doing a residency in the subject involved, and then you've taken clinical and oral exams and passed and satisfied a board that you're competent enough to practice the specialty.
Okay. Can you please walk us through your educational background, starting with undergraduate school and going forward?
Sure. I graduated in 1975 from the University of the Witwatersrand, Johannesburg, South Africa. I then did a year of internal medicine and surgery internship at the Johannesburg Hospital. I was then drafted into the military in South Africa and spent 2 years serving there as a military medical officer. I then spent 6 months doing an anatomy lectureship at the university. And then I entered an internal medicine residency program at the Johannesburg Hospital and spent 4 years doing that and got board certification. I then entered a neurology residency at the same hospital and spent 3 years doing that and became board certified. And then in July of 1986, my wife, child, and I emigrated, and I went to University of Massachusetts Medical Center in Worcester and completed a 3-year residency / fellowship program. And then in July of 1989, I joined a group in Marietta called Marietta Neurology and Headache Center and spent about 25 years there. And then I went to join a neurosurgeon called Premier Neurosurgical as neurologist in his office and practiced with him for 4 great years as an employee. And then unfortunately, he took ill and left us. And I joined a group called Georgia Spine, orthopedic group, but I was the headache division. And it was called Neurology Institute for Headache and Concussion. And I left there after 4 years, and a year ago, almost exactly, I joined Hope Neurology. Brings us to date.
Thank you, doctor. Could you tell the jury what you do generally in your practice?
Currently, we treat predominantly patients that have had head trauma and accident-related injuries.
Okay. Do you treat patients who have had neurological issues due to spinal cord trauma?
Yes, we do.
Do you perform any surgical procedures in your practice?
No.
Doctor, would it represent a substantial hardship for you and your patients if you were to be subpoenaed to testify live for a week trial in Spalding County, Georgia?
A hardship, yes.
Okay. Doctor, was Lewis Bennett your patient?
He was?
Is he still your patient?
Yes.
How did Lewis Bennett become your patient?
I believe he was referred to me by the Georgia Spine Orthopedic Division, and he saw me as a referral from them.
Doctor, I've got, I'm going to hand you what I've marked Exhibit 1, and I'm going to represent to you, I'm sorry,
I'll just use yours. Okay.
all right, and I'm going to represent to you, this is a certified copy of your medical records.
It is.
And before the deposition, you and I compared the chart that I have in Exhibit 1, or the chart that you have and the treatment notes you have, and determined that the treatment dates that you saw my client were the same, starting in August 18, 2020, and going to January 17, 2024.
Correct.
Okay, doctor, are these medical records kept on our computer system so you can look up the record if you need to review it
They
for
are.
a patient? Okay. When did you first see Lewis?
It was the 18th of August 2020.
Okay, when you first see a patient, do you have a protocol that you follow in order to formulate a diagnosis of the patient?
Yes.
What is that protocol?
Well, the initial thing is when you walk in, you look at the patient, see how they look and how they talk and how they answer your questions, and then you take a full history.
Okay. And when you saw Lewis, did you take a history from him?
Yes.
And what history did Lewis give you in terms of why he came to see you?
He is that time was a 52-year-old African-American gentleman who worked as a driver and was driving his vehicle on the 1st of July 2020, and he was wearing a seatbelt, and apparently a large trailer forced him into the guardrail and he struck the dividing wall. The patient told me at that time he did strike his head, but there was no loss of consciousness. He was able to get out of the vehicle, and no ambulance came to the scene. And the driver who hit him, apparently it was a hit and run, so he chased after the driver, got into the vehicle and drove. And the police came, and then the patient was later after able to drive himself home.
Okay. Doctor, you mentioned that you observed the patient when you initially encountered them.
Yes.
What was your initial observation of Lewis's physical condition when you saw him on that first examination visit?
Well, he was fine. He was sitting and talking and able to communicate and relate things, but he's walking, and that comes later when I examined him. Clearly he was having some difficulty with his gait.
And what does that mean, gait?
Walking, ability to walk smoothly and without falling.
Okay. And how would you describe the difficulty he was having?
At this point, I hadn't examined him and I hadn't formulated an opinion. Sorry, what's your question? You want me to go to the end?
How did you, based on your first observations and interaction with Lewis, what did you suspect might be medically wrong with him, and how did you go about scientifically investigating whether that was indeed the case?
So we're looking at the situation where he could have a post-concussion syndrome, or he could have had neck or back injury, or he could have had deeper structures abnormal like spinal cord injury.
Right. And after you took the history, did you physically examine Lewis?
I did.
Please describe what you did to examine him.
Well, the first part is obviously the awake and alert and oriented and cognition and speech, and he was fine with all of the components tested. Then we test the cranial nerves, and these are 12 nerves that supply the face and tongue and facial structures, and those were all normal. I tested his motor strength, and just sitting, his power was fine. There was no obvious weakness. He had a little bit of weakness in his left arm, and his left bicep muscle seemed to be a little bit wasted, which means, some nerve problem. His sensation, ability to touch and feel pinprick was fine. His reflexes were fine. and there was no evidence of Parkinson's disease or anything like that.
After you took the history and did the physical exam, did you do any testing on Lewis?
On the first day, I believe we may have, let me check. Yeah, he'd had an MRI of his cervical, and he'd had several because he'd had problems before he saw me. But I didn't do any testing further on him that day.
Okay. Did you do any MRI testing after that day?
I don't believe so. He'd already had the studies done.
Okay. Did you look at the studies that he had?
I did, yeah.
And what studies did you look at?
Well, there was the study from the emergency room visit when he presented there a week or so after his accident. And what struck me was the significant disc herniations with spinal cord pressure and swelling in the spinal cord. Then I looked at studies that he'd had. Then he ended up having urgent surgery, and there were some post-surgery studies which I reviewed, and that was it.
Okay. And the studies that you reviewed, were those MRIs?
Yes.
Okay. And can you explain to the jury briefly what is an MRI and how is that different from an X-ray?
An MRI is a very sophisticated imaging technique. There's a lot of physics involved in it, but essentially what it does is it picks up tissue detail and detail of organs, and there are different densities that come up on the picture, and the radiologist can identify abnormalities and problems.
Could you see Lewis's spinal cord on the MRI?
Yes.
Could you see any damage to his spinal cord on the MRI?
Yeah, he had evidence of, there was compression of the cord, and he had evidence of some swelling and edema in the cord.
Okay. Did he have any lesions on his spinal cord?
Well, that would be a lesion. If
Okay.
he had swelling or edema, it's called a lesion.
Okay. How extensive was the damage that you saw on his spinal cord?
It was quite severe. He had a lot of narrowing, and he had quite a lot of what we call it myelomalacia, which is swelling or edema of the cord.
Okay. And you mentioned the word edema. What does that mean?
Edema means swelling.
Okay. Did you look at the Did you look at the MRI report?
Yes.
Okay. I'm going to hand you a copy of that MRI report from. I believe it was July 7th, 2007. Is that the one you're speaking of?
2007.
Sorry, July 7, 2020. I'm sorry.
Yeah.
Is that the one you're talking about?
If I view it and say yes.
Sure.
Yes, this was the one done after the trauma, correct.
Okay, could you turn to the second page, please?
Yes.
It talks about, on number 2 under impression, it mentions signal abnormality with central spinal cord centered at C3-4, representing cord edema, contusion, or myomalacia. Was this written by the MRI doctor?
Yes,
Or
the radiologist.
Okay. Did you agree with that impression?
I did.
Did you see a contusion on his spinal cord?
I did. I've seen pictures of it subsequently, yes.
Okay. And what did the swelling and bruising on Lewis's spinal cord indicate to you about when the cord damage occurred?
Well, it indicates that there's an acute trauma to the spinal cord. And when I say acute, it could be a day or it could be up to a week or 10 days. And spinal cord changes can occur after that too. One of the problems we see in patients that have had spinal cord injuries is the small little blood vessels supplying the spinal cord, because of the swelling and the trauma, they get impacted, and the patient ends up with more spinal cord damage from the vascular side of it. And that can often be delayed. It doesn't have to happen the minute the bullet goes through. It can happen a week or so after. They can develop a progressive, we say a myelopathy, which means a spinal cord problem.
Okay. And the word myelopathy means
That just means spinal cord, and it's been called delayed cord syndrome and various things.
Did what you saw on Lewis's MRI film verify a scientific medical basis for the symptoms that Lewis told you about?
Yes.
Were Lewis's symptoms and physical problems that you observed on his exam consistent with what you would have expected from a patient with a spinal cord damage that you saw in his MRI.
Yes, sir.
What was your diagnosis of Lewis after your physical exam and film review?
Diagnosed, obviously, person injured in a motor vehicle accident. He had neck pain. I diagnosed neck pain. I diagnosed cervical disc with radiculopathy because of his biceps, so that's nerve roots. And then a myelopathy, which is the spinal cord problem. And then he also had concussion symptoms like post-traumatic headache.
Doctor, what is central cord syndrome?
It's a syndrome where the spinal cord is impacted, but the central core rather than the peripheral. So what happens is the fibers on the periphery tend to be relatively spared, but the central fibers that are coming down from the brain to the peripheral of the body get affected.
Okay. Doctor, I see you have a model here, and I've got a full spine model if that helps you, but can you please explain to the jury what you mean when you talk about central cord and peripheral nerves and those types of things?
Yeah, sure. How much can you see that on there? This is a picture of a spinal cord. It's only a small segment. It's the lumbar, but the anatomy, the cervical is higher up. The neck part is higher up. It's very similar. And you can see, if I turn it around, that's the front, and you can see the bony discs, the bony bone, the vertebrae, and then the discs in between. And if you take a disc out, it looks like that. So that's what a disc looks like. Now, if you have enough force, you can herniate the center of the disc. It's kind of like a donut. And if you squish it, the chocolate filling will come out. And that's what this looks like here, this red part. Now, what can that do? Well, you look at the spinal cord from the top, and you see it's about as thin as a pencil, and it goes from the bottom all the way up to the brain. And it runs through a canal called the central canal. And this canal, thank goodness, in most people, there's a lot of space there, and you have no problems. But if you have a little bit of degenerative arthritis, it's a little narrowing. And if you have a wreck and you get a bad whiplash or even hit your head, it becomes more compromised. And certainly if you herniate a disc, you end up with a squishing of the cord and the myelomalacia, the edema that we saw. And finally, you can end up, if it's the center of the cord that's impacted, the little blood vessels get affected and the center of the cord becomes abnormal. That's called a central cord syndrome. So there's a whole spectrum of things that can happen. The other thing, these nerve roots coming out on the side, and he had some pain left arm and some wasting of his biceps. That just indicates that one of these nerve roots is impacted as well, and it's caused that.
Thank you, Doctor. Doctor, do patients who suffer spinal cord damage from central cord syndrome typically have anatomical differences that make them more susceptible to a cord injury?
Well, as I mentioned, if the cord is narrow now, there are some people that have a congenital narrowing. They're born with it. Dad had it, granddad had it, and they are more prone. If they get a seemingly minor injury, it can impact the cord more severely than someone who is lucky enough to have a wide canal.
Do you think that, or did you observe that Lewis had a heightened spinal cord injury risk because of his particular anatomy with respect to his cord canal?
I think the degenerative changes may have contributed slightly, but I think the main contributor was that big disc that came squishing out and impacted the cord.
Okay. Now, Doctor, there's been testimony from medical providers in this case that there doesn't even have to be a major trauma to cause central cord syndrome, and that an unexpected movement of the head or neck a certain way can cause that. Do you agree?
I do agree.
Okay. And can people with crowded anatomical spinal structures be more susceptible to severe spinal cord injuries from a minor trauma?
They can.
What kind of movements or impacts can trigger spinal cord damage from central cord syndrome?
The worst one is the flexion extension, the classical rear-ended whiplash.
Okay.
However, it can be any direction at all. Even lateral movements, if severe enough, can produce it.
Okay. Now you mentioned flexion and hyperextension. Could you just show the jury what you mean by that?
Flexion means if you get struck from the back, your body goes forward, you hyperextend, and then your head goes forward.
Okay.
If you get hit from the side, it happens side to side.
Okay. And any of those movements, extension, flexion, or side to side, is it your testimony that any of those could cause central cord syndrome?
They can.
If Mr. Bennett testified that his head moved forcefully forward, backward, or side to side during the encounter with defendant's truck, could any of these movements have caused his central cord syndrome based on his anatomy?
Yes.
All right, I'd like to talk to you now about the onset of the symptoms from central cord syndrome generally, and for Lewis in particular. Now, do all spinal cord injuries, in your experience, cause immediate paralysis?
No.
What kinds of spinal cord injuries cause immediate paralysis and which do not?
There's a long list of different diseases that can affect the spinal cord. A patient will go in for surgery, abdominal surgery, and they'll cut the wrong vessel or clamp the wrong vessel, and there can be a stroke or an infarct of the spinal cord. That's immediate. There can be obviously trauma, a bullet wound, anything severe. The commonest cause of spinal cord injury is older people. They get older, and you can't avoid that. There's arthritis in the neck, and gradually the central canal gets impacted. And then if you're unlucky enough to fall off a curb or get in an accident or whatever, you can really impact that trauma and cause the problem.
Okay. And does central cord syndrome, in the way you described, does that always cause immediate paralysis, or can that be delayed?
It can be delayed. As I mentioned earlier, there's the swelling, there's the disc, there's the immediate trauma, and then, of course, there's gradually, as that swelling increases, little blood vessels get impacted, and the blood vessels come in from the outside of the cord, and they run into the center. So if you impact that area, you get the problem at the center. That's where they end up.
Doctor, you took a history from Lewis, and I believe you said there was no ambulance call and that he did not seek immediate care at the scene?
He said that.
Okay. And are you aware that after he was talking to the police after the incident, he said he did not experience any symptoms for several hours?
He did say that.
Okay. And are you aware that Lewis has claimed his symptoms started gradually several hours after the truck accident and lasted about a week until he had his
Yes,
surgery?
he, I think, went back to the motel where he was staying,
Okay.
and then they gradually got worse.
All right, I'll show you Exhibit 4. Have I sent this to you previously? And I'm going to represent to you that that's a deposition of Lewis Bennett that talks about what he experienced, the onset of his symptoms
Yes.
from the time of the incident until he went in for surgery.
Correct.
Have you reviewed that?
I did.
Okay. And does that symptomology concern you in terms of the onset of his symptoms and whether they're related to the truck accident?
No.
Okay. What is post-traumatic cervical myelopathy?
Cervical myelopathy means a pathology or problem in the neck area. Myelopathy means of the spinal cord, and post-traumatic, after trauma.
Okay. And what is a vascular spinal cord injury? I think you talked about that briefly.
That can be part of the traumatic, or it can be independent, like the patient who had surgery and they clamped off the wrong vessel and he got a stroke of the spinal cord.
Okay. And by vascular, are you talking about a stroke or vascular? What does that specifically mean, vascular?
It just means that a blood vessel got obstructed and it ended up impacting the cord.
Okay.
And that's, of course, in the lower abdomen or thorax. It's not cervical.
All right. Doctor, at our request, did an animation technician hired by our firm reach out to you for guidance about how you think Lewis's spinal cord injury might have progressed over the 6 days in question?
Yes.
I'd like to show you that animation now, please. Okay, doctor, in your opinion, does the animation that you just saw accurately show the progression of Lewis's spinal cord damage?
Yes.
I'm sorry, let me just get done with my question.
Sorry.
Your Honor, we have a little bit of technical issue. The animation was supposed to be showing at that time.
Okay. Do you want to just keep playing it, or is that supposed to be in part of, at that moment?
Yeah, it should have been playing in that little, where the video like kind of glitched for a second.
Okay.
Do you want us to play it?
I'm just looking for what do y'all need.
Your Honor, I think it might be easiest at this point. It's been played in Dr. Chapman's. It was part of Dr. Red's. We'd moved to tender into evidence Exhibit 51, the animation, and we'll just play that minute deposition if that's okay, since that's the point where it was.
Your Honor, we obviously object. It's argumentative, it's continuing testimony. I mean, it's a demonstrative, it's not evidence.
All right, so
It's not a
for,
medical record.
yeah, so for now, I'm just gonna hold off so we can keep this going and finish lunch, and then I'll give you an official ruling later, but it is a demonstrative. You played it in your opening. And I'll allow you to play it at the conclusion of this or wherever you want to tie it in. Because I did anticipate seeing it as part of the demonstrative of this. And then I'll come back to that if we need to. So it's a demonstrative. You may continue moving forward.
Can we play it now, Your Honor?
Yes. It's a demonstrative, so you may.
Wait, are they playing the demonstrative exhibit or playing
Yeah,
the
they're
video?
showing the demonstrative because they're saying the demonstrative should have played at that moment on the screen. And so I'm just letting them play it as if it was there.
Just state the record, we object to that.
Okay, that's reasonable. All right, you may continue. Tell me again what that number was.
That was Exhibit 51, Your Honor.
51? Okay. All right, you may resume playing the deposition.
Okay, Doctor, in your opinion, does the animation that you just saw accurately show the progression of Lewis's spinal cord damage?
Yes.
I'm sorry, let me just get done with my question. In your opinion, does the animation accurately show the progression of Lewis's spinal cord damage from the date of the incident until the date of his first MRI showing that spinal cord damage?
It does.
There's a part of the animation that reads vascular changes in inflammation. What does that mean? And can you show us on maybe on the spine model?
Yeah, just
How that would take
one
place.
can't really see it on this model because it's very small and narrow, but this is the spinal cord here, and vascular changes means that there's some blood vessel abnormalities resulting in damage to the cord.
Okay.
And you can see it on the animation. They did that quite graphically, how it gradually progresses.
Doctor, in the animation, the neck is moved back. I think you said that was an extension where it's moved back.
Yes.
Okay. Does the direction in which Mr. Bennett's neck moved matter for the purposes of showing the progression of his spinal cord damage in the animation? Could you, in other words, could you get the same, would the same results of the progression be there whether it was an extension, a flexion, or a side-to-side movement?
You can get the same result.
Doctor, based on his history, his films, your physical examination, and your interaction with Lewis, do you relate his spinal cord damage to the truck accident of July 1st, 2020?
Yes, I do.
Was the truck accident then the reason for Lewis's spinal cord compression, the 2 decompression surgeries, and his present physical and neurological condition?
Yes.
There was a video which showed Lewis getting in and out of his truck and walking around right after the accident with no apparent physical limitations. Would that be an issue that would cause you to doubt your opinion that Lewis was injured in the truck accident?
No.
Now, are you aware of the surgeries done by Dr. Chapman and Dr. Bendix?
Yes.
Dr. Chapman, I'll represent to you as the ER doctor in North Carolina. To your understanding, why were these surgeries done?
Well, the first surgery was done when he presented to the urgent care, then the ER, and they did the scan, and wow, he had a big herniated disc pushing the cord. And in order to prevent more damage, one has to remove and decompress that area, and that's why they did surgery urgently.
Okay, and could you just use the model and explain what the decompression, what that means specifically?
Yes, I believe they, one of the problems is this is the cord, and these are the discs, and one of the discs is herniated back, kind of like you see over there, and it's pushing the spinal cord. So the surgery is aimed at, they go in, I think, either from the back or from the front, depends on the surgeon, and they will do a laminectomy. They open the bone, and they do a discectomy. They remove that herniated protruding disc from the cord.
Doctor, does Lewis still have significant problems with his neurological system as a result of the spinal cord damage?
Yes, he does.
Can you explain why, in your opinion, the surgeries that were done did not fix his spinal cord and why he's still having problems?
Well, it depends on the extent of damage when they go in to the operating room. There's some patients that have a big herniated disc and they have surgery and they're 100% fine. But there are a few where the cord damage has already occurred. And once you've damaged the spinal cord, it's a long road back, if at all. And I think the purpose of that first surgery was to prevent more damage and to stabilize the spine. And then, of course, Dr. Bendix did a second fusion to prevent any further deterioration.
Okay. Doctor, how many times have you seen Lewis in total since 2020?
Probably about 6 times.
Okay. And when was the last time you saw him?
I actually saw him 2 days ago.
Was that a telemedicine visit?
Yes, sir.
Were you able to observe Lewis?
I did from the waist up. You know, it was telemedicine, so limited from lower legs point of view. But he was, I could see him, yes.
Okay. And what neurological symptoms did Lewis still have?
He was still complaining his main problems were gait, walking, ability to balance. He was using a walker a lot of the time, and you'd use a cane if he was just around his house. He was still complaining of episodic nausea, which he had all along, which makes sense with a concussion, episodic headache. And the other problem he was having was bladder problems. He'd had problems with urination, which we do see after spinal cord trauma, but he'd also had a history of this before the bladder issues, neurogenic bladder problems. So I don't believe a lot of that was related. And he'd had a cystoscopy, a cystostomy, which is a little hole so the bladder could drain. And he was finding that painful and inconvenient. In fact, had been to the emergency room last weekend because it was painful.
Thank you, Doctor. Does the spinal cord damage that Lewis suffered, that you observed on your first visit, and since you've observed that up till 2 days ago, is that something that will ever heal?
No.
Are the spinal cord issues and physical disabilities that Lewis presently has permanent?
Yes.
Has Lewis therefore reached maximum medical improvement for his spinal cord issues?
Yes.
Are Lewis's neurological symptoms likely to get better, worse, or stay the same as he gets older?
I think they'll stay the same, but there's obviously always a risk of falling, and that would make things worse. There's a risk of infection from the bladder point of view with sepsis, and that could make things worse.
Is there any surgery or treatment that could help him with these problems that he's having neurologically?
From the spinal cord point of view, no. From his bladder point of view, I'm not a urologist, so there may be something novel and new they can offer him.
Speaking of the bladder, you had mentioned neurogenic bladder. What is neurogenic bladder?
It just means a bladder abnormality on a neurological basis.
Okay. And what are the symptoms of that condition?
It can be either urinary incontinence or it can be urinary retention. And then very, very rarely, but with a severe trauma, they can even have bowel problems, bowel incontinence.
Okay. Have you been in touch with Mike McCord, a life care planner in this case?
I believe, yes, he sent me some documents which I reviewed.
And did you talk to him about those documents and agree with him on the number of visits that Lewis is likely to see you going forward?
I don't remember talking to him, I may have, but I did look at them and agree with it, yes.
Okay. All right, Doctor, I want to show you some prior medical records of Lewis from 2013. Show you exhibits 5, 6, 7, and 8. Now, have I previously sent these to you?
I think I have a few things here, yes, from 2013.
Yes, sir.
Yeah, not
Right.
many though.
Have you reviewed these before?
I did, yes.
Okay. And I'll represent to, or you tell me, what do these appear to show from 2013?
Let me make
These
sure I'm
medical records.
talking about the right one. The one was a blunt head trauma, which happened back in 2013, and he had a forklift flipped over and he struck his head, and that was a concussion. And apparently didn't leave him with any problems after that. And the other one was, this was a sports med. The other one was, it was just in his records that he once got assaulted and he had a superficial neck laceration and they had to repair that.
Doctor, was either the neck laceration or the 2013 concussion that he got with the forklift, are either of those at all relevant to his spinal cord damage for which you treated him?
I don't think so, no.
Doctor, you mentioned that you specialize in treating patients with concussions.
Yes.
Could you just explain what a concussion is specifically and what causes a patient to suffer a concussion?
Concussions are due to trauma, and contrary to what is believed, you don't have to actually hit your head to have a concussion. If you have a significant whiplash, front to back or side to side, with or without hitting your head, the brain inside is a very sensitive bowl of jello, and it gets banged like that at that instant and produces some neurochemical changes that produce a symptom complex called post-concussion syndrome. And there's 4 or 5 things. There's headache, there's dizziness, there's neck pain, problems with memory and cognition, and those are the main features of concussion.
And did Lewis report he had symptoms of dizziness, headache, nausea in the days following the wreck?
He had the main component of his, well, from the accident point of view, was nausea. He had a lot of nausea, vomiting. But other than that, he had neck pain, but nothing else.
What about, did he report to you any weird vision problems?
He said that when he coughed or sneezed, his vision would kind of dim. And I didn't quite know what to make of that.
Okay, are dizziness, headache, nausea, and vision issues symptoms of a concussion?
They are.
Take a break.
We're back on the record.
Doctor, are dizziness, headache, nausea, and vision issues symptoms of a concussion?
Yes.
If Lewis suffered these symptoms in the days following hitting his head on the truck's interior during the time he was run off the road, or just from his head being, I guess, moved about while he was trying to avoid the accident, would you consider it likely that Lewis suffered a concussion from this truck accident?
I think he did, yes.
Now, doctor, did Lewis ever report any other traumatic event happening besides the truck accident before his symptoms began?
I can't recall. I think other than the forklift accident, and then he was assaulted once and stabbed in the neck, no others.
Okay. Have you ever been contacted by Dr. Bruce Frankel from South Carolina, who's a doctor that the defense hired in this case?
No, I have not.
Now, are you aware that the defense hired a doctor who speculated, this Dr. Frankel, that Lewis may have become paralyzed or suffered these issues with his spinal cord by vomiting a few days after the wreck?
I read that.
Okay. What is your opinion on that?
In my 35 years experience, I've never heard of that.
Okay. If Lewis vomited as a result of the concussion that Lewis sustained when defendant ran him off the road, then was Lewis's vomiting a direct result of the truck accident that defendant caused?
Check the form.
I think it was, yes.
Doctor, if Lewis reported that his neurological symptoms, including paresthesis, numbness, tingling, things like that, occurred before he vomited, could vomiting be the cause of his central cord syndrome?
No. I mean, I looked at that and thought about it, and I can't figure out how vomiting could do that. Otherwise, everybody who goes out on a Friday night and gets drunk, and vomits crazy, they'd all end up with spinal cord problems. It's unheard of.
Doctor, just finishing up here, was Mr. Bennett a cooperative patient?
Yes,
Was he a compliant patient?
yes.
Did you ever have any reason to doubt Lewis's description of his condition or his credibility in describing what happened to him?
No, sir.
To your knowledge, were the charges, your office charged Lewis reasonable and customary rates for the Metro Atlanta market?
I believe so.
Doctor, do you give all your opinions to a reasonable degree of medical probability?
I do.
Doctor, that's all the questions I have now. I may come back and ask you some further questions when defense counsel has after he's cross-examined you.
Yeah, Dr. Maloon, my name is Clinton Fletcher. I'm the attorney for Transcontinental Cares and Occidental Insurance. Thank you for sitting today. You obviously got started your training in South Africa, correct?
Yes.
All right. Did you practice at all in South Africa?
No.
Okay, your entirety of your practice has been here in the United States.
Correct.
Yes, and as you mentioned, you've kind of been affiliated or worked for a number of practice groups, correct?
Yes.
One of those is the Marietta Neurology and Headache Center, right?
Correct.
Were you a principal of that practice group?
I was a shareholder. There were
Okay.
five of us, I believe.
Okay, and that was an LLC?
No, it was a
PC?
yes.
PA?
I don't know. I'm not an attorney. It was incorporated. I don't know what it. Yeah.
But nevertheless, you were a shareholder of
I
that.
was a shareholder. Yeah. We were partners.
Now, you talked about earlier that you first saw Lewis Bennett in August 18 of 2020, right?
Correct.
All right, if you want to pull up that first record.
Sure.
The top of the note says reason for appointment.
Yes, sir.
Okay. Now, in terms of this progress note, it is a progress note of you, correct?
Correct.
Okay. Is it fair to assume you had a nurse take his blood pressure?
Yes.
Okay.
I noticed
But
that.
But for purposes of your testimony today, it's fair to say that the information contained in this progress note, you entered or dictated, correct?
Correct.
Okay. In fact, on page 3, you electronically signed the progress note, right?
Yes.
All right. In terms of your progress note, you testified that when you're treating a patient, you put down your observations of the patient, right?
Correct.
But you also take in any statements from that patient, correct?
Yes.
All right, when you're taking the statements of the patient, you're relying upon that patient to tell you the truth, correct?
Correct.
Okay, because it's important for your treatment of a patient to make sure that that patient is telling you the truth, correct?
Correct.
All right, it helps you provide the proper course of treatment for that patient based upon what they tell you, correct?
Correct.
Okay, let me point out in your note, you said patient did strike his head, but there was no loss of consciousness. Is it fair to say that that statement is based upon what Mr. Bennett told you?
Yes.
Okay, and you're relying upon him to tell you the truth for that statement, correct?
Yes.
All right. And then 2 sentences later, you have the driver apparently was hit and run, and the patient changed after him in his vehicle. It's fair to say Mr. Bennett told you that a truck hit him during the accident?
And drove off. Yes.
Okay, so there was a contact between Mr. Bennett's truck and another truck as far as you understand Mr. Bennett's description.
Yes.
Okay. Again, you rely upon him telling you the truth as to what happened.
Correct.
Okay. All right, now in the next paragraph, 2 to 3 days later began to experience nausea, headache, and dizziness. That's based upon Mr. Bennett telling you the truth, correct?
Correct.
All right. Now, Dr. Maloon, you're a full-time doctor with Hope Neurology, correct?
Correct.
You're putting in roughly 40 to 60 hours a week here?
About 30 to 35.
Okay, but there's nothing in terms of your physical health that prevents you from working, correct?
I have bad hips and bad backs. I couldn't walk around the hospital, but nothing from working here.
Okay, your bad back and hips, does that prevent you from sitting?
No?
Okay. Now, with respect to your hours, I think you talked about your practice group here going from seeing patients from a Monday to Thursday, correct?
Correct.
And then Friday's just basically administration.
Yes.
Okay.
And that's just been a week that's been happening.
How's it going?
Nice to be off on a Friday.
All right. So on Fridays, you're not seeing any patients, right?
No.
As we sit here today, did you do anything to prepare for today's testimony?
I did. I put together everything sort of in a chronological order, and I did review the animation which we had shared. And other than that, no.
Okay, and when you talk about the chronological order, those are your records for Mr. Bennett, correct?
And my record, well, they were records from St. Joseph Chandler, the ER visit on an issue when he, sorry, let me say strike that. 15th of October 2013 was a visit in the ER back when I think that coincided with the previous trauma. And then there was a Dr. Scherer's note that I looked at as the post-concussion syndrome when he hit his head. There was a note from July the 7th, 2020, which was from the ER, the date he went into after the truck accident. And then Georgia Spine, I've just got one page, and then my notes follow after that.
Right, the Georgia Spine, who provided you those records?
I believe it was on the same EMR, so we could access. It was a Dr. Bendix's note.
Okay.
And it was one page.
And you were once partners with Dr. Bendix, correct?
We weren't partners. I was Alan Maloon PC, and he was Georgia Spine, and they were administering the practice.
All right, now with respect to the concussions, you talked about earlier, I think your testimony was that concussions can be interesting in that you can have symptoms years later, right?
Correct. They can be protracted.
Okay, and you testified earlier that you were aware of Mr. Bennett suffering a concussion when a forklift overturned, correct?
Correct.
All right, but then your testimony to Mr. Scholl was that Mr. Bennett was not suffering any symptoms of that forklift accident because he did not have any complaints, correct?
Correct.
Okay, and if you knew about complaints, they would be reflected in medical records, right?
It would be. Yes.
Okay,
Should be.
it would require Mr. Bennett to seek medical care to note if he was having any residual symptoms of that forklift concussion, right?
Correct.
Okay. Now, you testified earlier that it's your belief that the central cord syndrome with Mr. Bennett was caused by the July 1, 2020 accident, right?
Yes.
All right. You talked about an MRI that was taken on July 7th, 2020 at the emergency room in North Carolina, that there was indication of trauma to the spinal cord,
Correct.
right? In terms of and you reviewed that MRI, right?
Yes, and the report which I have.
Okay. In terms of that MRI, you'd agree with me that it's impossible to say when exactly that contusion started just based upon looking at the MRI, right?
Most of it, there's a lot of edema. It's commented on swelling, and edema swelling occurs acutely or shortly thereafter. So from that point of view, in his clinical presentation, I think it was acute.
Okay, I understand you're acute, but just looking at an MRI, it's impossible to look at an MRI to say when a contusion started, correct?
Correct.
You would rely upon the subjective statements of the patient telling you when they first started feeling symptoms, right?
Correct.
All right. It's only based upon your conversation with the patient and looking at the MRI that you can come to the conclusion that the damage to the spine was acute.
Correct. Does this fit in with what the patient's telling you or what the patient looks like now?
Okay. And you testified earlier that the onset of symptoms of central cord damage, acute central cord damage, can be a day, a week, or even 10 days later after an injury.
Correct. They can be slightly delayed.
Okay. And so the only way to confirm if there was damage that happened after the accident with the MRI is to compare it with an MRI prior to the accident, correct?
That would be very helpful.
Okay. Now, based upon the onset of symptoms, it's not impossible that an injury could have occurred before the accident and then the symptoms showed up around July 7th.
Well, I think he would have complained about that in his history. We have to take the history at face value
And
and believe him.
Yeah, and the history is based upon the honesty of that patient.
Correct.
Okay. And now also, if the onset of symptoms after the accident, some violent trauma after the accident could also cause the symptoms to arise, correct?
It can. Repeated trauma, certainly.
Okay. Now, in your testimony earlier, you agreed with Mr. Scholl that any movement of the head, be it light or heavy, could cause central cord syndrome.
It can if it's extreme enough.
Okay, well, let's understand, please explain to a jury, what is extreme enough?
We don't know, because we see patients that have a simple rear-end car accident and they have no symptoms. And then we see patients that have had the same kind of accident and they have terrible problems. So there must be an angle of traction laterally or anterior posteriorly that results in the problem.
All right, Dr. Chapman, who we deposed, who was the emergency room orthopedist, testified that, strike that, give me a second. Yes. Dr. Chapman testified previously that anything like a daily activity of leaning back in a barber's chair could cause central cord syndrome. Do you agree with that?
Very rare, but it can happen, yes.
Okay, so that you would agree with me that that kind of daily living of leaning back in the barber's chair would be kind of like a minor movement of the head, correct?
It's usually without force. When you lean back in a barber's chair, it's kind of hopefully a gentle movement, gradual, whereas if you suddenly get impacted in a car accident or fall down the stairs, it's more vigorous.
There is testimony that Mr. Bennett suffered a vomiting attack after the accident, correct?
Correct.
But yet your testimony was that such a vomiting attack would not be forceful enough to cause central cord syndrome.
I've never heard of it.
Okay.
I think it was more likely to be the concussion that he suffered.
That was causing the vomiting.
Correct.
Okay, but what about the vomiting causing central cord syndrome?
I've never heard of that relationship.
Okay, but you would agree with me that vomiting could be a movement of the head similar to leaning back in a barber chair.
Well, I think vomiting might be leaning forward more than back, but I don't see how it could cause it physiologically.
Okay, what if it's an immediate attack of vomiting and he jumps forward, throws his head back to throw up wherever he needs to throw up?
Extremely unlikely.
Now, Dr. Bendix testified that he believed the cause of Mr. Bennett's central cord syndrome was a hyperextension backwards. Do you have any reason to disagree with that?
It could be lateral, or hyperextension. I agree with that.
Okay, but if Dr. Bendix was going to say the cause of the central cord syndrome was hyperflexion backwards, there isn't anything that you're aware that would disagree with him, right?
Correct.
Right. In terms of the nature of the accident, your understanding of whether it was benign or violent in terms of the motions in the accident are only based upon Mr. Bennett's description, correct?
Correct.
You're obviously not an accident reconstructionist, correct?
Correct.
All right, you're not a biomechanic who studies the forces on the human body and what the body does in reaction to those forces, right?
Correct.
All right, you only treat patients as they present to you, correct?
Correct.
All right.
Because you see, the anatomy in everybody is about the same. and the physiology, the way the body works, is about the same. And we've learnt in medical school that when something goes wrong with the anatomy or the physiology, it results in a disease or a pathology. And we've learnt through our years of training that certain things have certain patterns. So a whiplash, a bump on the head, a trauma now coming, even if it's a day or two or three or four later, with a spastic weakness in your legs, and then an MRI that shows an area of edema and swelling, A plus B plus C. It just makes more sense.
Okay. With respect to Mr. Bennett telling you that he struck his head, but there was no loss of consciousness, you'd agree with me there's no note in here that indicates that he suffered any laceration to his head, correct?
Correct.
And there's no note in here that he suffered any outward contusions on his head, correct?
Correct.
All right, if he struck his head on the steering wheel, there's nothing noted in your treatment note that he had a bruise that looked like a steering wheel, correct?
Correct.
All right, and in terms of your note in your evaluation of Mr. Bennett, there is nothing in there that indicates if there was any outward indication of a head strike.
Outward, no, but inward, yes.
That wasn't my question, just outwardly.
Yeah, outward, no.
Okay. And again, in terms of when the symptoms of someone hitting your head, that would be based upon the honesty of the patient telling you when they hit their head.
The history, yes.
Okay, that wasn't my question. It's based upon the honesty of the patient telling you when they hit their head.
Correct.
Right. Now, you talked about just a second ago that people have typical structures, physiology. Is that fair summary of what you just said?
Repeat that, sorry.
I think you just testified that you said people have typical physiology, correct?
Yes, it's the way the body functions.
Okay. And in terms of the way the body functions, the body changes with age, correct?
Yes.
And some people, the body changes differently for each person, correct?
Correct.
All right. In this case, you, in your treatment of Mr. Bennett, he had degenerative changes to his neck, correct?
Correct.
To his spine.
Yes.
Okay. And those degenerative changes, those are based upon his age, correct?
To a degree, yes.
Yeah, his constitution or how he is as an individual, correct?
Or his age, I think.
Okay. But the degenerative changes to his spine were not caused by the accident, correct?
Correct.
Okay. But it's your opinion that the degenerative state of his spine allowed him to be more prone to central cord syndrome depending on the acute injury, correct?
Correct.
All right. But the accident did not cause this degenerative spine condition.
I don't believe so. I think that was pre-existing.
Okay. Let's talk about the bladder. You testified earlier that in your review of the medical records, Mr. Bennett had a bladder condition prior to the accident.
Yes, there was an ER note that referred to bladder and constipation.
Okay. And you're going to testify in this case that whatever incontinence or bladder issues that Mr. Bennett's suffering were caused by the accident?
One of the spinal cord trauma findings is bladder incontinence. So I'm going to answer you and say yes, I think it did contribute.
Okay. So if he claimed he had bladder incontinence prior to the accident, they're completely unrelated?
It may be, if he claimed it was so, yes.
Now, the animation you saw that was presented here, you agreed that that was a proper animation for the cause of central cord syndrome.
Yes.
All right. And you believe that animation properly reflects the hyperextension of Mr. Bennett somehow during the accident?
It does in the pictures, yes.
Okay. So that the video and the animation was a hyperextension of the neck
Yeah,
backwards?
something variant of that, yes.
Okay. But the animation
Could have
that...
been a lateral or hyperextension, correct.
Okay. The animation that you saw, you'd agree with me that it was a hyperextension backwards?
Correct.
Now, you talked earlier about reviewing a life care plan from a Mr. McCord. Do you remember that?
Yes, sir.
Okay. And in terms of that life care plan, did you, other than looking at the life care plan, did you actually see if it was accurate in terms of the numbers that were presented?
I looked at it briefly and it seemed to be in keeping, yes.
In terms of the recommendations for changes?
Number of hours, yes, and yeah.
All right, in terms of the changes to any of the house, including a ramp or a disabled bathroom, you're not going to offer any testimony as to the cost of those?
No.
Okay. And if there is any testimony in this case from an expert talking about Mr. Bennett's ability to work in any capacity, you're not going to provide any opinions as to what types of work he's capable of, right?
No.
And you're not aware of any expert in this case who's testified or provided testimony as to what type of work Mr. Bennett is allowed to do, right?
No, I have not.
If you could go to your treatment of Mr. Bennett on September 29th, 2020.
Okay, I have it.
Okay, in your interim history, this is again you taking down what Mr. Bennett told you, right?
Yes.
All right, you say in this note, patient says he is maybe slightly better in terms of gait and ambulation, right?
Correct.
All right, that was described to you by Mr. Bennett, correct?
Yes.
Okay. Now, if you jump down to the second paragraph, it says, at this time I'm reviewing his MRI. I think the primary problem is the central cord issue, and fusion would not help. Did I read that correctly?
You did?
Okay. That is your medical opinion in terms of this note at that time, correct?
Yes.
Okay. I'd like you to turn to your treatment note of December 22, 2020.
Okay.
All right, you on page 2, you have assessments. Do you see that?
Yes.
Okay. You have listed assessment of myelopathy and diseases classified elsewhere.
Yes.
Okay. And diseases classified elsewhere, that's meant to describe acute injuries?
It's really just broad. It's any cause of myelopathy, and that's just the DSM categories that come up.
Sure. Is there a DSM? There's a DSM category for acute injuries, though, correct?
There most likely is, yes.
Okay. And you didn't provide that
No.
code? No. Did you look to see what, is it fair to say that you didn't list other diseases that could be related to myelopathy?
No, because I think that it was probably, not probably, I think almost certainly related to the trauma. There was no need to look for other things.
Okay, so if you place the DSS code for the acute injuries, then why was it necessary for the extra code for diseases classified elsewhere?
I don't know, that's just the code. When you type in myelopathy, that comes up as one of the options, and you just click on that option.
That's not an unnecessary code for Mr. Bennett?
No, I think it's appropriate.
In terms of these two treatments, or two visits that you provided me the documents for, one is August 8th, 2023.
Yes.
Okay, that's your handwriting at the top?
That is, that was I did that the other evening, getting ready for it. And my PA saw the patient on that first visit.
Okay, so on August 8th, 2023, your PA saw Mr.
Yeah, and then
Bennett.
I review his notes and sign the note.
Okay, in fact, so
But
on
the second one, I saw him.
Okay, so on page 4 of this August 8th, 2023 visit, it says e-signature Alan Malone.
Yes, correct.
So that indicates that you reviewed the notes, right?
Yes.
And that you approved them?
Yes.
And you approved the recitation of the subjective comments of Mr. Bennett?
Correct.
Okay, and then on January 17th, 2024, did you see him yourself?
Yes, that was the telemetry visit. I did.
Okay, that was the Zoom video.
Correct.
Okay. All right, turning to August 8th, 2023, when you or your physician's assistant or nurse, when they're taking, do they take the comments from the patient again?
No, they take the current comments, but the past history, as you see in front of you, was taken from a previous note, probably from when he saw me at Neurology Institute for Headache and Concussion. So that's just copied and pasted in there as background.
Gotcha. So if any statements of the patient changed because they may have remembered something differently, then it should be in the notes, correct?
Should be underneath, at the end of that, there's this piece where patient is now complaining of this, that, and the other.
Okay,
Current.
but in terms of the description of the accident, if anything changed in his remembrance, he would hope that he would tell you, correct?
He would, yeah, if it came up, he would, yeah.
Okay, so in terms of this visit of August 8, 2023, where he says that he did strike his head, but there was no loss of consciousness, you're assuming that that is still true based upon what Mr. Bennett prior told you, right?
Yes.
All right, because if he had remembered something differently, you would assume that your PA or yourself would note that, correct?
He may have, if he volunteered it. He may not have volunteered it, and then we're just taking, what we got from before.
Okay, and it's, the description of the accident I'll represent to you is the same in August 8, 2023 and January 17th, 2024. When you reviewed them, you would agree with me that Mr. Bennett's description of the accident remained the same based upon the initial visit, right?
Correct.
Okay, and you would agree with me that Mr. Bennett still represented that his tractor was struck by the other tractor, right?
Yes.
Okay. I got no further questions.
Doctor, just a couple of follow-up questions. Do you disagree with any of the surgeon's decision to perform decompression or fusion surgeries on Lewis?
No.
Doctor, whether Lewis hit his head or whether it was forcibly moved from side to side, could either one of those things cause a concussion?
And certainly, yes.
Okay. Did any questions that the defense counsel asked you on cross-examination change any of your opinions that you've given in this case on direct examination?
No.
Thank you, doctor.
Yeah, just one more. Yeah, Mr. Scholl just asked you a question, and he used the word forcefully to describe the movement of Mr. Bennett's head.
Yes.
Whether the movement of Mr. Bennett's head was forceful or not, that would be based upon Mr. Bennett's description of the accident, correct?
Very often it is, but if you've ever been in an accident, things happen so quickly, the patient not be aware of, unfortunately there's no videoing what happens, so we very often don't know, and we have to rely on what the patient perceived has happened.
Okay, so the description of a head forcefully moving, whether it hits something or not, that's based upon the the patient's perception.
Correct.
Because obviously, like you said, there's no other corroborating evidence that you know of that actually shows Mr. Bennett's movement in the truck, correct?
Correct. I'm relying on what he's telling me, what he perceived went on in that split second of impact.
Okay, well let me ask you this. If there is expert testimony in this case that the force placed upon Mr. Bennett during the accident was no worse than someone sitting down in an office chair, would you provide the opinion that such action of sitting down in the office chair would cause central cord syndrome?
I don't agree. I think that sitting down in an office chair is a pretty gentle, and also going to the barber shop, as we mentioned earlier, it's usually a pretty gentle hyperextension.
Okay, so you would not expect central cord syndrome to arise based upon someone simply sitting down in an office chair?
Correct.
Okay, no further questions.
I'm going to introduce
Are you
Exhibit
off the
14, the MRI report.
All right. Members of the jury, there was an objection during it. I'm going to rule on it this time. The court finds that plaintiff's Exhibit 51 is a demonstrative exhibit and is sufficiently similar to the tendered testimony to allow admission, and that it may be potentially assistant to you. And I find that on the 24-403 Balancing Act, I'm supposed to do that. The charge to you all is as follows. Members of the jury, the plaintiff has tendered a demonstrative animation illustrating the plaintiff's theory of the case related to the plaintiff's alleged injuries. Although this video purports to incorporate certain X-ray images of the plaintiff, this video is not actually a video of the actual plaintiff, but is simply a demonstrative animation. This exhibit will not be available to you in the jury room. This animation is being presented to you by the plaintiff for demonstrative purposes only, according to their theory of the case. As with all exhibits, you must decide for yourself what weight, if any, you wish to give this exhibit. All right, those are the charges as to the animation. All right, anything else, Mr. Scholl? On that or anything else?
Your Honor, we have some exhibits we'd like to tender.
Okay.
And, I believe we're ready to rest. If we could maybe have lunch to look through our exhibit list and just come in as a formality and rest at that time. We don't have any more witnesses though.
All right, then I think that's a good thing for us to do outside the presence of the jury. Do y'all have, do we have anything else we need to address while the jury is still here before you break for
Let's
lunch?
do these last two exhibits.
Go for it.
That I know of at the moment.
Sure.
Plaintiff's Exhibit 54, this is the surgical diagram that Dr. Bendix was referencing and holding up during his testimony. Again, it's a demonstrative.
All right, any objection from the defense?
Same objection as the animation, Your Honor. It's demonstrative, it's continuing testimony, it's not a medical record.
Okay,
Your argument.
as far as admission goes, it's admitted. As far as the continuing objection goes, that is sustained. We will deal with that at the end of the case. Anything else, Ms. Stabs, on that? All right, then it's part yes, part no. So, all right, go ahead.
And I believe on Tuesday, when we read the admissions from Transcontinental, we did not actually tender the copy into evidence that we were presenting.
All
So
right.
that's a subpart of Plaintiff's Exhibit 80 that we gave you on Tuesday.
Your Honor,
I have no objection if they're gonna submit the full response, but this is just a summary they're created for purposes of reading it in. I'm not sure that's the full response to the request.
No, we can put in the full copy, but I only have one copy of that. I don't have a full copy to provide.
All right, so that version in your hand is what you all actually read?
Yes, sir.
All right, and what number is that?
Plaintiff's 80.
All right, we're gonna call 80, that one is 80, we'll do 80A or 80.1, which will
Or
be
I
the
can
full.
I can do this 80B.
That'd be
and
fine.
then the full copy 80A.
But also it's continuing testimony. Your
That
Honor.
part is granted. So you all can explain that to the jury in closing arguments, what they will and will not have with them in the jury room. So, okay.
And I'll give you 80A.
All right, and so we'll have an 80, this isn't officially labeled Terry, 80B is in Bravo. So, all right, and then 80A will be the full. Okay, any other housekeeping before we give the jury lunch?
no, Your Honor.
Any other housekeeping, Mr. Fletcher?
No, Your Honor, on behalf of Transcontinental.
All right, thank you, Ms. Stabs. Thank you all. All right, members of the jury, it is 12:30. Again, as you just heard, the plaintiff very much likely intends to rest when we get back from lunch. We're going to do some housekeeping outside of y'all's presence to make sure we have all the boxes checked. And then after lunch, we will pivot to the defense, where they have the opportunity, but not an obligation, to present defense witnesses. I'm sorry, I need my coffee. Exhibits. And we'll go from there. During the break for lunch, members of the jury, while you're outside of this courtroom, do not talk about this case with anyone or conduct any investigation whatsoever. You may only receive information about this case from two sources: the evidence which you'll receive from witness testimony exhibits and the law that I will give you, and no other source. I trust that you know the rule by now. Again, I just can't say it enough. These attorneys and their parties have worked for years to get here. We are so close to the finish line. Please don't take any steps that would cause any difficulty in this. And why am I saying that? Because it's happened. So don't be the next one in my story on that one, please. All right, with that said, you all, it's 12:30, so I'll have you all back here at 2. That gives us a little time to do housekeeping. So be back here about 1:59. We'll start at 2. If you need anything else, let the bailiffs know. All right, you all are released until 2 for lunch.